we were talking about the chamber being maintained and other things, you did see a couple of times when the chamber was shallowing a little bit as I was hydrating. When I removed my irrigation port, a little bit of fluid came out, but the IOL hardly even moves around. And of course, in the later post-op period also, it helps that the tips, which are a little roughened, ensure that the rotation of the IOL doesn't happen so easily. So once it's been aligned in place, we find that the results are extremely predictable and consistent with the next story.
Also, Shreyas, what viscoelastic did you use for your Rexis?
Sir, I just used, normally I use only HPMC. In this case, I used a little bit of cohesive viscoelastic to flatten the capsule before the initial nick was made, so that although I did anticipate that it would only be a fluid cortex and it'll be easy to remove, but you never know that the amount of intralenticular pressure that could exist. So it's better to inject a little bit of orogel, flatten the capsule, make a nick, so that it's a controlled opening, and then as the fluid comes out, I go in and aspirate with a cannula or sometimes even IA, and once it's aspirated, then the entire Rexis becomes very simple.
Perfect. So if there's any other question, Dr. Mayank, Dr. Kirti, any other question? Otherwise, we are going to let him go. I'm sure he's in a busy OT today. So thank you so much, Shreyas. We've had a wonderful
Thank you, sir.
session.
Thank you so much
nice
for the
surgery
opportunity.
done.
Thank you, sir.
And,
Thank the entire Ophthacon Ophthalmic Association for this opportunity. Thank
so
you,
Dr.
sir.
Kirti Singh wants to say something to you.
Yes, sir.
Additional information that what we do very often, again, we leave air. I find leaving air reduces the inflammation. I don't know what your experience is. Pehle we used to say there's no need to leave air. Why? It's cause. In fact, in trabeculectomy cases also I leave air.
Okay.
And it really not only just flattens everything out, next year the inflammation is definitely less.
Okay.
Yeah.
Yeah. So I don't I've not tried that.
Only thing it additionally does is tamponades the inflammation downwards. So the endothelium is not that exposed to that inflammation if it is on an exercise.
We've been doing that for all the residents training. We just find that it really helps.
I think air used to be our favorite, like when we were training, and over time, I think we've lost the touch with leaving air inside the chambers. But we did use it a lot. Like whenever there was a problem, you leave air inside. So anyway, thank you so much, Shreyas. Wonderful having your presentation. Thanks.
Thank you so much, sir. Thank you, sir.
So I think we have a quick break for lunch, and we are regrouping at 1:45. So please, I would request everybody to have a quick bite. We have 30 minutes, and then the Alcon session will start with some very interesting surgeries. So we have a break for 30 minutes, and I'll request all the conveners and panelists and all the delegates to be back for a very exciting, including I think a retina surgery and a Innovise Wavelight Plus LASIK surgery from Noida. So we'll have some good, interesting stuff.
Recording in progress. blurry twin.
पापा
Huh?
सेठी अंकल की कैटरैक्ट
What a shot! Did you see that? पिछली बार जब मैं सेठी के साथ था तो उसे कुछ समझ में नहीं आ रहा था. ना स्कोरबोर्ड, ना प्लेयर, ना लाइट्स, everything was blurry twin.
पापा सेठी अंकल की कैटरैक्ट सर्जरी हो गई है अगले मैच में सब दिखेगा
Clarity वापस आ गई. सेठी की.
and he's not dependent on glasses anymore.
वाह गुरु, विजन भी वापस आ गई और चश्मा भी उतर गया. एक तीर से दो निशान है.
He chose a multifocal lens implant option so it lets him see both far, near and even intermediate distances.
भाई वाह.
The right lens in life or surgery can truly change the game, Dad. वैसे आपने अपना रेगुलर आई चेकअप करवा लिया क्या?
बस अगले हफ्ते ही जा रहा हूँ. जिंदगी भी ना मैच डे की जैसी है. कभी क्लियर स्काइज, कभी ओवरकास्ट, but when you have a brilliant vision, you can play along it.
Talk to eye specialist about the advanced cataract lens implant options today.
पास होकर भी पास नहीं और दूर होकर भी दूरियां वहीं. नजरों का बदलो अब ये नजराना. चश्मों को मत बनाओ नजरों का परवाना.
अब मैच देखें.
Hello. So we are all set, starting the Alcon session, and we've had a wonderful sessions in the morning so far. We've had 3 sessions already, and I see from Eye Care Noida, Dr. Saurabh Chaudhary and Dr. Shalini are going to be logging in, and we have some interesting talks coming up. And I see Dr. Ramamurthy, who's been online for a while. And welcome, Saurabh. I can see you now. And Ramamurthy sir, we would love to have you on board as well. I do see Dr. Kumar Doctor, but he's been there since morning, but we haven't seen him. We only see his ghost presence there, so it's okay. We are going to start off with the Alcon session, and we are taking on, because of internet issues sometimes creeping in. Right now we have excellent internet, so we are requesting Dr. Saurabh Chaudhary to go ahead. We have several surgeries lined up today, and thank you so much for joining, Saurabh, from Eye Care Hospital in Noida. Please tell us what all you're planning to showcase. So we can't hear you, Saurabh. Can you have, maybe are you unmuted? We don't hear you. We don't hear you, Saurabh. No, no. So you are unmuted, as I can see on the Zoom, but we can't hear you. We don't hear you.
And he's only went for Zoom call.
Gaurav,
Now we can hear you.
so I think it's
We can hear you now.
okay, you can hear me now. Perfect, perfect. So,
Welcome to NZOS UKSOS meet. Let us see you with your surgery. Your screen has been shared, but the video is not switched on.
sorry, I can't hear you very well, but can I start?
Yes, please go. Is the audio clear?
Am I audible?
Yes, you are audible. What about us?
Okay, okay. So I shall start because I can't comprehend what you are saying from there, but let me just start. Right.
Okay.
Right. So, thank you to the NZOS and the Ophthacon Society to invite me for this deferred surgery session. It's the first time I am in a deferred session, so let's see how it goes. We have operated on this patient yesterday, actually, but what I understand is that most of it is an unedited sort of a video. So let's start here. I was asked to showcase a video on the Wavelight EX500 with the Wavelight Plus sort of. This is the newer software, as well as the hardware, which is available on the EX500, and it now gives us the option to do a true wavefront guided surgery vis-a-vis a wavefront optimized surgery, which was earlier on. Now, what is the difference is that earlier on it was a customized surgery, but now it's a fully personalized surgery. And what the main difference is that we are using, besides the topolizer, which had already been introduced quite some time back, which took over the oculizer, now we have something what we call as the site map. So I'm showing you the video of the site map. This is the acquisition sort of a screen what is there, and it's on a laptop. And as you saw earlier, that the patient was in a dark sort of ambience, and our technician was taking the readings. So in this, more than 130,000 data points are taken to make a virtual model of that particular eye. So earlier on it was a gold strand model which was being used. Now the particular eye is being used, and so that's the major difference. Because now we are talking about a personalized sort of a treatment in which each eye is being treated differently. Now, in case we notice here that the acquisitions have been taken, and this basically, besides the topolizer, which is giving us the topography of the eye, the site map gives, it's an abrometer, it's a true abrometer, and we get the wavefront data from it, besides the tomography, which is the OCT data. So that is also coming to us. And it also incorporates all the pentacam data what we have, besides the biometer. So biometry, in the sense, it is giving us the IOL, the axial length, and all the other parameters besides the calculation formulas in the what it is available in the other biometers. So we're getting all this data which is incorporated all together, and once this is incorporated together, we go ahead and treat the patient. So this is the planning station what we have come to, where this patient is a Mayo with a 0.5 cylinder and a -6.5 diopters of sphere. So what earlier we used to do was to put in a subjective sort of a refraction in this, but here you do not have to put it, because the data is now moving in from the site map. That is the InnoEyes machine, right onto this so that we are able to get this data, and we usually don't play around with this data. So the access, the cylinder and everything has been pulled up, and there's a nomogram which changes it a little bit. So we go ahead with this. These are the pachymetry maps which are showing up, and then we go ahead and we do the planning. So the final parameters are there. If you're looking here, all the data in fact it's
Saurabh,
the
I was
refractive
seeing
and the corneal details, treatment
Saurabh, can you
details.
pause it
So
for a moment?
here we are going onto the machine. All the data has been moved seamlessly, so you don't have to put it into the machine anymore. So it is on the LAN system. It goes onto the machine. This is the femto case, so we already raised up a flap. This flap is slightly decentered towards my right, but it has enough sort of exposure, so I'm going ahead with the normal. So there is no difference in the treatment protocols in the sense that it is exactly what you do on a EX500. So you're taking the center of the eye, and here we are now tracking the eye. So the tracker goes down, and we've tracked the eye. So that's the green fixation target, and red are the focus targets. And just because there was a little bit more exposure there, I'm just trying to protect the unlifted part of the cornea there. And the treatment is over, and it just takes the same amount of time what it usually used to take. We go ahead and then we clean the bed here, and then as we clean the bed, we'll deposit the. Now, in case you notice, I still do mark all my corneas, and the reason is not for losing the flap, but it's just that once I put my flap back again, I am sure that I will not get any microstriae if my marks on the flap and the peripheral cornea are matching. So I start widening out, I make sure that these marks are matching, and if they match very well, I am sure that I will not have any microstriae future. So as I said that in the wavefront optimized, we are actually working on the full strand model of the eye, but here the site map is actually making a virtual model of the eye, and it is being treated accordingly by taking the abrometer, taking all the readings from the retina, the vitreous, the anterior and the posterior surface of the lens, the interior and posterior surface of the cornea as well. So that is how the treatment is different from what it was. So whatever was what we used to call as a wavefront optimized has now become a true wavefront guided technique, and all the abrasions in the eye are also treated with this. It is supposed to be the next step and of treatment of myopia as well as mild orders of hypermetropia. This is the second eye what is being treated, so there's nothing different from the first eye. And as I said, that it uses more than 130,000 data points. The machine has actually removed the reliance of any sort of programs in the treatment for streamlining the planning, and gives a very predictable outcome. With this we have an opportunity to give a fully tailored refractive treatment. So there is something extra here also, that it takes into account the corneal tissue healing factors for long-term stability of the refraction, and that's what we are actually doing. As I did talk about the hypermetropia, we can actually not do hypermetropic treatments in them. I'm sorry, it's only meant for myopia. It's been approved for a FDA only for myopia at the moment. But though you can do the hypermetropic treatment, but it's not FDA, right? So that's the regular case, as I did say. So there's nothing different from a regular case besides the extra hardware and the very refined software which is helping us do these treatments.
Wonderful. Saurabh, can you hear me now?
Thank you. I'll take any questions if there are any now.
Yes. Can you hear us?
Yeah, I can hear you vaguely, but just go ahead.
So what I wanted to ask you is that in what percentage of your practice are you able to, I mean, it's still a new thing, so you may not be doing big numbers, but from like what percentage of patients qualify for this, and which are the ideal patients who would benefit from an Innovize treatment over the wavefront optimized?
So when I The first thing is how many patients we are doing. It's about 20% of our refractive practice, so we don't have a big refractive practice. Those are shifting onto the InnoWise, but we're in a different marketing area as well, because sitting here and so close to Delhi and so close to South Delhi, as all would understand, that we do have to have something which is equivalent to the others. So that's why the whole system came into our practice. Now, once we have this, we do see that there is a little benefit of this over the other patients. Which patients disqualify for it? I think only the hypermetropes disqualify for it, and those patients who have a higher cylinder as compared to what a sphere is. So those patients we are avoiding to do it at the moment, because the FDA also has not recognized it for those patients. But otherwise, any other patient can go ahead with this, and according to what the theory is giving us, it will definitely benefit the patients if they're going in for a wavefront customized treatment versus a wavefront optimized treatment.
So, but Saurav, is it
Now,
FDA
in the
approved?
initial stages, what we did also was that for the first few patients, we only did a WFO treatment for one eye and a wavefront customized treatment for that. It was equivocal, and some of the patients did say that the wavefront guided treatment was slightly better. So once, though a study has to be done on that, and we are planning to have a study, but at the moment, what we would say is that yes, there is a benefit of the wavefront guided technique over the wavefront optimized treatment. Now, the sphere, what we usually treat is up till -11. So that's the benefit, that because earlier on we used to treat anything above -10, but the FDA has given a clearance for up to -11. I haven't treated those high myopes as of now with the wavefront guided techniques, and I am taking all the other parameters what I would choose for a wavefront optimized treatment for a wavefront guided treatment. The cylindrical treatment options are up to -4 currently, but I believe that they're going to increase this as more trials, more world over will come out.
Dr. Ramamurthy sir, do you have experience with the Wavelight Plus and the InnoWise? And what are your thoughts about it? And you are a very keen refractive surgeon who always understands refractive surgery very well.
Oh, very nice presentation, Saurabh. My query would be, you took the refractive error right from the site map. If there's a difference between the refractive error between the site map and the patient's acceptance, do you still entirely go by the site map refractive error? I mean, do you have that much confidence in that?
Right, sir. So the next step, what we usually do is get the patient back onto the refractive table, and we now onto the from Snell's chart. Basically, what we try to do is see if the patient is accepting what the wavefront guided, the abrometer is giving us as the readings. And more often than not, the patient do accept, and they say that it is slightly better what they see with the abrometry readings rather than just the subjective treatment. So once this was happening, yes, our confidence on this increases quite a bit. But any patient at the moment, because it's early days, any patient who have a more than a -0.75 diopters of sphere, we are still changing the data in the wavefront guided treatment and treating them accordingly. But as the time is going by, our confidence on the whole thing is increases. And as I said, why? Because the patients are feeling slightly better with the wavefront guided. With what the readings have come out with the wavefront with the abrometer than just the subjective refraction.
In case, there is some residual error that's left over, which is uncommonly happens in any refractive surgery, would the approach for enhancement be the same, or you have to handle them any differently?
So till now, we haven't had a case where we had to do an enhancement, but what I understand is that it is exactly the same. So we get the patient back onto the refractive table, do a subjective refraction, and then get the patient onto the abrometer and see what the results come out from there. And if they're matching, we just close our eyes and go ahead. And otherwise, if they're not matching, we get the patient back onto the Snellen's chart and see what is better for the patient. whatever the patient's responses are.
Saurabh, can you do this on the surface as well? I mean, do you have to make a flap, or you can do this on the surface?
Sorry, was that a question to me because I couldn't
Can
hear?
you do it as a PRK also, like the Wavelight Plus treatment? Can you do it as a
Yes,
PRK?
yes. So PRK means yeah, we're doing the Epi Wavelight Plus treatments as well. So the criteria is actually the same, and the management, the planning and everything is the same as what it is for a Wavelight Plus. But again, Epi Wavelight Plus is not approved by the FDA. It's still not been approved, but we've done a few Wavelight Plus Epi treatments.
No, but does it combine with Streamlight, or you have to do it like a brush assisted or something
You
else?
can actually combine it with the Streamlight as well. So
But you have to feed it as two treatments or a
myself
single
is not a big
treatment?
advocate of Streamlight. So basically, we do a lot more of the epi treatments with alcohol. So that's what we have done till now.
So can you combine it as a single treatment with Streamlight, or they have to be two treatments? Because then there is a gap
No,
of
as I said,
almost
that you can combine
30
it.
seconds.
As you said, you can combine it. So
Okay, great. And when did the Wavelight Plus treatment get FDA approved?
sorry.
How long? When did this get FDA approved? How long back was the FDA approvals which came
How
out?
long back did the Wavelight Plus get approved? The US FDA approval, when did it come? I myself is not very sure, but I think May of 2025.
Okay, perfect. So if there's any other question, otherwise we'll go on to your second case, Saurabh. Can we go on to your second case?
Yeah. So the second case is a clarion toric IOL by Dr. Reena, but Dr. Reena is not available at the moment. But there's some Dr. Shalini Sharma will be taking over and just going through her case. Right. So I'll ask Shalini Sharma to come onto this table because we're all sitting together here in our meeting room.
Sure, thank you.
Thank you, Harsh.
So the screen shared is still the same one. Can we switch to the second case screen, please? I think you'll have to stop sharing and then share again, only then it will come. First you have to stop sharing the screen and then share again from the PPT which is open up on your laptop. Can you hear us at iCare? Hello? If you can hear us, you can stop sharing the screen and then share from that PPT again, then your PPT will come.
So, good afternoon, everyone. Am I audible, sir?
Yes, Dr. Shalini, right? We can't see you, but we can hear you. And we are seeing a screen which is still showing the folders. We don't see your video yet.
Am I audible, sir?
Yes.
Yeah,
You're audible.
So, good afternoon, everyone. I'm Dr. Shalini. Dr. Reena is not there. So, this case was operated by her. This is a age-related cataract.
So, we are not seeing your screen.
And we plan to...
Dr. Shalini, we don't see your screen yet. We are not able to see your screen.
I can't hear you well, sir.
You have to stop sharing and then start sharing again.
No, you have to stop sharing, Ms. Shalini, and then
okay, sir.
reboot and show the video.
Okay, sir.
Yeah.
And now you can share again. Then, I think she logged out. Okay, yeah, perfect. Now we can see you. Perfect. And now if you share your screen, I think we'll be able to see the screen as well.
Okay, sir.
Yes. Now you can go to the... Yes, now we can see yours.
Yeah. So, can you hear me now and see me as well?
Yes,
Yeah.
very much.
So,
very
good
much.
afternoon, everyone. So, this is a case operated by Dr. Reena. She is not here. So, I am presenting her case. This is a case of grade 2 age-related cataract. And we plan to implant Clarion toric in this case using the Alcon suit, which comprises, there are 3 components in this. There is a Argos Virion, and there is a Centurion machine, and we are using the microscope, Rivalia microscope by Alcon. So, so we have made the entire planning of the surgery on Argos Virion. We are not using the biometer which we normally use after having this Varion over here. So it is a highly accurate biometer for all kind of eyes. We can use it for high myopes and hypermetropes as well. And it gives a very superior axial length acquisition even in dense cataracts, matures and hypermatures, which were earlier we were using manual if it is not even matures and hypermatures, which we cannot use the usual IL Master 700. Varion gives a very accurate axial length measurements by the ERV technology which they have, and the precision in the Varion biometer and the surgical planning helps us the surgical precision in the OT. So we can decrease whatever the risk of when we are using the toric lenses. It decreases the risk of transcription errors, and it increases the accounts for the cyclotorsion which comes up when we are doing the manual marking for the toric lenses. So here the planning of the surgery has been done, and this is our OT. The case has been taken under. We started the registration on the Varion in the OT. No manual marking is required, and it gives it is a digitally guided, because here you can see the main incision and the side ports are also guided by the Varion machine. So the accuracy which any of the incision or SIA, it can be compensated because the precision is very significant by using the Varion during the intraoperative procedure. The exact position of the main incision can be made, as you all can see. We have not done any manual marking for the toric IL placement. And the microscope which we are using is the Rivalia. This is a fantastic microscope, and we have been using it for quite some time. It uses a illumin eye technology, and it has a very larger, 6 times larger image formation, which gives a very stable red reflex during the procedure. So the LED which they use gives a much larger image, and the depth is 65 times millimeter additional to what we normally get in the microscope. So we don't need to keep on adjusting the focusing. The depth of focus is very large. So we don't need to refocus ourselves when we are operating again and again, because the depth of field is very large as compared to the normal microscopes. And as you can see in the OR, the Varion is there, and machine we are using is the Phaco machine which we are using is the Centurion machine. And so we have done the rexes, we have done the hydrodissection, and now we are starting with the Phaco emulsification by using the Centurion machine, which is active Sentry machine now. And the beauty of this machine is that it gives the active surge mitigation, because the sensor is there in the probe which we are using, and so the AC depth maintenance is very good. There is no surge at all, even when the vacuum decreases, when the occlusion is there during the emulsification. There is no, by this machine, it compensates for any kind of leakage in case it is there. So we start, the chopping is done. chopping, beautifully maintained AC depth throughout the procedure. So by using this platform of Alcon suit, which all we can in one go, everything can be pre-op, intra-op, can be recorded, can be, we can plan the surgery better by using the Varion. Cortical aspiration being done. So nice red glow you can see, beautifully clean PC. We are preparing for the lens, we are loading the lens. Clarion toric. So for the toric aisle, Varion, you can see the markings are there and it is so easy and so smooth. We can implant the lens without any manual marking, a hassle-free loading and implantation. Here it goes. So we have to place at 176 degree, which is already we can see through Varion, we can easily implant it over exact toric implantation can be done without any error. Very important to remove thorough visco removal, which Dr. Reena is doing beautifully, going under the lens. So we are joining the dots of toric aisle with the superimposed image through Varion. So together with this microscope, Rivalia and Argos Varion and Centurion machine, we can have absolutely seamless, smooth procedure, pre-op and intra-op. So it's done, sir. Any questions?
Hello? Hello?
Hello, yeah.
Yeah.
Yeah, sir.
Okay.
Yeah.
Very nicely done, and of course the markerless toric alignment system is amazing. I just wanted to know, as compared to maybe the Master 700, how often does the Argos, kind of capture cataracts which are not taken by the Master 700? I know that you guys have both. So how often do you see like more opaque cataracts where the Argos is able to get the axial length but the 700 is not?
So, especially in our practice over here, we are maximum cases we are directly using Argos Varion, because in hypermatures and matures and in hard dense brown cataracts, where there was some error with IOL Master 700, and where we were doing manual along with IOL Master 700, now directly we are going with Varion, and the results are fantastic. We don't need to do any manual biometry apart from IOL Master 700 now. The maximum cases we are going through Argos Varion only.
So you're not doing cross-checking your biometry with the Man-1 immersion biometry?
Sorry, I'm not able to hear you clearly. Please, can you repeat the question, sir?
Yeah. So no role of immersion if you are doing with Argus in even hard cataracts?
There is a lot of echo. Voice is not clear. I'm not able to get the question.
So Dr. Panthi is asking that you don't have to cross-check your Argos axial lens with immersion in hard cataracts?
No.
Like if you have an opaque cataract, are you able to get 100% opaque cataracts now, or are there still some cataracts?
Yeah.
Wow.
Yeah, initially we had tried on for some time back. Can you hear me, sir?
Yes.
Yeah, so to start with, we have cross-checked after doing the Varion biometry. We have cross-checked with the immersion, and the results were absolutely same. So now we have stopped cross-checking.
Okay, great. Dr. Ramamurthy, do you have experience with the Argos at your center?
Yes,
Sorry?
we do have experience. We do have experience with both the Argos and the Master 700. Both are excellent machines. But as far as your specific question about penetration is concerned, Argos definitely scores over IOL Master 700. I won't say that in hypermature cataracts and total cataracts you can get a reliable reading. There's still a small percentage of cases where you have to go to an immersion A scan. But the chances of getting a reliable reading with the Argus is a little higher than with the IOL Master 700 in advanced cataracts. This has been our experience.
Yes, sir. Yeah.
But Argos does not capture posterior corneal astigmatism, right? So you have to still rely upon the anterior corneal astigmatism. So that's one place where it misses out. But otherwise, I think it's an excellent machine. Right?
True, you know, posterior corneal astigmatism, even when you had the IOL Master 700, was more relevant only in cases like post-refractive surgery scenario. Otherwise, in the Barrett calculator, whether you use the measured posterior corneal astigmatism or the assumed corneal astigmatism, the results are quite all right. So maybe when you are talking about doing post-refractive corneas intraocular lenses, maybe the IOL Master 700 has a slight advantage.
Also, does it come with any other formulas which are very productive, which were not available on the other biometers so far?
So I'm not able to understand the question. Sorry.
Dr. Ramamurthy sir, could you understand what I asked? Like, do we have any IL calculation formulas which on the Argos which are very productive and new, which are not available on the other biometers so far?
It has the Kane formula also, but we also use the mostly the Barrett suite of formulas in it.
Okay, great. Any other questions, Dr. Mayank or Dr. Kapil? So I think we'll move on. I think we're running a little late now. Thank you so much, Dr. Shalini, and for at the last moment filling in for Dr. Reena, and we wish her well. So thanks a lot to all the eye care team for joining up. We'll move on to the next talk. I think the other talks, Dr. Ramamurthy sir, you can stay on because we have a couple of talks from the hall itself. So we would love to have your comments. And Dr. Saurabh would, if he can stay on, or Dr. Shalini, we would love to have you stay on as well.
Thank you, sir. Thank you so much.
Lutfa presenting his deferred dive surgery from Ancon.
We have that. All right. So, can we keep the volume a little less? It's too loud, I think. So I'll be showing this one case which came to us. This patient presented to us. He's a doctor himself. Okay, I won't move it now. Don't worry. So, this is a 54-year-old male patient who came to us with diminution of vision in only one eye, noticed only 3 months back. But he seemed to have a fairly advanced cataract, 618 and all improvement. On taking detailed history, we gave a history of possible history of trauma a few years back, and other than that, there was nothing, and it was a unilateral cataract more or less. And a fellow eye patient had 6.6 unaided, and frankly, even though he was presbyopic, but he had some kind of intermediate vision available to him. He was only using +1 glasses for a very fine print work. That's his cornea. We did the biometry, and after a detailed evaluation, the retina check, we tried to look for any pars planitis and other reasons for the cataract, but there was nothing else. This was identified, there was only a 0.31 at 96, so it did not show up as a, there was no need for a toric lens, otherwise we use a toric whenever indicated, even for very small astigmatism, sometimes even 0.5 astigmatism we tend to correct. But here there was no need for a toric at all. And also when we looked at the Almaster 700 calculations, it showed up, we were trying to choose the first minus as we always do. Now the patient was given the option of both trifocal lens and also that of a EDOF. And patient somehow, because he had some amount of presbyopia, he was fine with having good intermediate vision and didn't want, he lives on the hills and he drives at night, so he didn't want any kind of dysphotopsias at night. So we decided to go with a EDOF lens, and when given choices, one of the favorite lenses that I try to use is the Alcon Vivity lens, which gives excellent distance vision and does not have any rings, so it does not give any dysphotopsias really. and has very good intermediate vision and even some near ability for most of our patients. And frankly, what I've seen is that when there is a unilateral cataract, usually patients do better with these EDOF lenses than with trifocal lenses. They take more time to adapt with the trifocal lenses. So we went ahead and then we also use the ESCRS calculator, which we use for all our premium IOL patients. And as you can see, this has about 6 formulas, and you can compare. There is a Cook, there is a EVO, and there is a Hill RBF, the Hofford QST, the Kane, and the Pearl DGHS. And they are all suggesting that we should use a 19.5 for the first minus, and that's what we decided to use. So this was the lens chosen, and this is, I'm starting the surgery. This was recorded a couple of days back, 2 days back, and we always check the lens, and we check all the biometries which are fixed on the wall there, and we look up the alpha and the toricity and all the other details of the patient on all these printouts, and then we can move forward. See that fibrotic band which is visible on the capsule, and I'll just show you the microscope view. We are using the Alcon Centurion system. This is a Rexus marker, even though I have a Callisto and a Virion, but I still like to use this simple Rexus marker which I have devised. It leaves a nice imprint on the cornea which lasts for about a minute or two. It's just enough for you to get your Rexus right, and this gives you a perfect 5mm Rexus, almost like a femtorexus, and it's just costing 2,000 rupees, and it gives you a few thousand cases can be done. So you can see that that Rexus mark which I created is perfectly aligned with what the Callisto thinks is the perfect 5mm Rexus. And I actually trust the Rexus marker more than the other devices. So here I'm anticipating a bit of a problem with the capsular Rexus because there is a fibrotic band which is running there, as probably because it's a traumatic cataract and there may have been some kind of inflammation which has set up this. So I am able to go through it. Many times your Rexus will tear, but because while I went through it, my Rexus became a little small. It's not the size that I wanted. I wanted a 5mm Rexus, but I've got just in this area, the superior area where the fibrotic band was. Beyond this, my Rexus became a little small, so I'll have to enlarge it later on. But for now, I'm completing the Rexus with a small micro Rexus forceps, and I'm stabilizing the globe with this globe stabilizer, which does not allow viscoelastic to escape from the side port, because it occludes the side port. So it's a nice tool for that too. And you don't have to hold, I don't like to hold my eyes with any kind of forceps or Hoskins or anything. I usually use a Johnson's bud, or I use this globe stabilizer which works well. So there I've got the Rexus right now. We are going to do a hydro dissection. And I'll have to be a little careful because in that area where there was that fibrotic band, sometimes the Rexus can give way because there was some resistance and I had to tear through it. Second fluid wave. Once you have 2 good fluid waves, you don't even need to really rotate the lens because almost always it will rotate. So then I'm ready for the job. I'm using the active centering on the Centurion, and I like to do a direct job. Also my side ports are calibrated, so I'm using a 22 gauge side port knife which gives me 1mm side port incision, and all my instruments which go in from the side port are also all calibrated to 1mm, including my bimanuals and even my chopper. You can see it expands as it goes in, so then it occludes the side port and I don't get any fluid escaping from the side port during the surgery. That way I can operate at IOPs of 20 or 25, and my chamber stability remains very well because there is no fluid loss from the side port and the main port. It's not a very hard cataract, it's a straightforward NS2, NS3 kind of a cataract. But the consistency is a little different because this is a post-traumatic kind of a cataract. And for a 52-year-old, you would have thought that the cataract will not be this hard, but it's a sticky kind of lens. I'm trying to create those cracks so that once the posterior plate is cracked, it will be easier. Now because it's not a very hard cataract, I can just tumble it out and get the nucleus. Now the active sentry has really made a difference because the active sentry has a sensor which is inside the handpiece itself. So So the IOP control, you can operate at much lower IOPs with almost no chamber collapses and no chamber surge. You don't see any surge, and that's why I enjoy the active sentry now. Although it's told that the active sentry handpieces last less long, but as long as they are working well for me in the last 2-3 years that I've been using them, they've been working extremely well. So you can see there that I was able to get nucleus out, and you can see my settings over there. I'm using a bottle height of, I'm using an IOP of 30, and my settings are usually very modest, and I don't use very high settings. Now you can see these calibrated side ports where my infusion and my aspiration, these are both customized handpieces which I've got customized for my liking, because these are high flow infusion handpieces, and they are both sandblasted, so and they are both made to 22 gauge. You can even get them in 23 gauge, so if you use a 23 gauge knife, you can use 23 gauge instruments. If you use a 22 gauge knife, you can use a 22 gauge instrument, and that way you don't have any fluid losses from the side ports. You can see that fibrotic band which is just under the capsule remains there. I'll have to deal with it in getting the cortex out. With this very fine sandblasting on the handpieces, it becomes easy because I can use either of my instruments. You can see I'm peeling that fibrotic band from behind the capsular rexus. So I've gone just behind that rexus edge, and from the undersurface of the capsular rim, I'm just taking off that fibrotic band which was stuck there. Usually it is like this only. So I'm polishing it a little bit, and then I'm doing a little bit of a PC polish. You can see there is that fine material which is stuck on the PC, and I'm just going very close to it, and with very low vacuum, I'm just aspirating it away from the crystal capsule. So now we are ready with the lens implant. This is the Alcon Clarion Unity, which is glistening free, and this is a better material that Alcon makes. It's been around for a few years, but I think all of us, if we use Alcon lenses, we should move to Clarion material. It definitely is in the long run better for the patient because there are no glistens. I'm again doing a hydro implantation as some of the other surgeons have shown since the morning. Now you can see that my rexus is smaller than what I intended, so I'm going to have to go and make that rexus a little larger. I'm using intraoperative OCT on my microscope to check how the IOL is placed in the back. Okay, so there I'm giving a small nick. I've gone from the side port, and under infusion itself, I have given a small nick on the capsule, and then I'm going to go in with my again, these are microrexus faucets which have been designed by me. They come in this way so that you can look through them. They have an opening, and you don't have to. It doesn't close the hand. Its claws, they don't close. So you can see I'm doing this under infusion. I have not used any viscoelastic, but because my side ports are calibrated and both my instruments are fine and there is no fluid escaping from the chamber, that capsular tag will not flutter around as it would normally do. If there was a fast flow of fluid and leaky ports, this thing would have been fluttering around and made it very difficult to maneuver. But when you have calibrated side ports, you have total control, and that's the CVT lens that has been implanted. You can see those typical rings, and they have to be nicely centered onto the reflex from the microscope. And I'm now trying to seal the side port and the OCT. You can see that my side ports are sealed. I'm still not satisfied, so I'm giving yet another nick because I felt my rexus was still not the perfect size. So I've gone in and I'm trying to enlarge it further again. And one more round of rexus tweaking. You can see under infusion, it still works quite well. Now I'm maybe better off with my rexus. It's not a beautiful looking rexus, but at least it is, the overlap is just right. You can see my incisions now. As I'm hydrating the incisions, my stoma will seal, and then I'll be able to be sure that my incision. This is very useful for my pediatric cataract surgery patients where I want to be sure that my incision is sealed, and also for some of those patients where there is a leaky wound, you can check whether it's the posterior lip or the anterior lip which is the responsible, and you can go and hydrate that if you have to. So now you can see here that the posterior lip is nicely sealed, and all of the incisions are sealed well, and I'm putting intracameral moxifloxacin. And this patient did really well. We saw him he's just operated 2-3 days back by me for the light surgery, and the patient did have next day excellent vision. He fairly good intermediate vision, and he's obviously be coming back for a 15-day follow-up, and we know, but with past experience, these patients do extremely well. So that was the case. If there are any questions, I'll be happy to answer. I think we'll invite the next speaker, ma'am. Because we are
Gaurav, your voice is not very clear.
Oh, so because I'm using the mic.
Now it's better.
It's better now? Maybe I
Yeah.
was speaking standing too far away. Any
Yeah,
questions,
it should
Dr.
have
Chitra,
been
ma'am?
good. No, we missed so much of your valuable thoughts. Many miss.
I'm sorry. If you had interrupted me, I would have, spoken again and maybe louder. But any thoughts on the Vivity? How do you like the Vivity compared to the other EDOF lenses?
Um, See, if we try to understand, it gives a EDOF, ideal EDOF should be 1, which gives you a defocus of at least 1 to 1.5. So Vivity does fall in that range, and it's being a little bang on biometry or a little plus would be an advantage for these patients.
So typically, what is the ad required by your Vivity patients, if at all?
So what we do, Gaurav, is to, essentially as you are mentioning, for the first eye aim at the first minus and the second eye aim at the second minus. So that bilaterally implanted you steal a little bit of myopia, and bilaterally implanted these patients' need for glasses is significantly less. Still for reading they might require a 0.75 or a 1 diopter, but quite a few of them don't require glasses.
Right,
But,
right. But sir, another question that comes to my mind now that you are saying this is that when you make these eyes into micro monovision, how good is the tolerance of the Vivity for how much does the distance vision deteriorate for patients when you choose a 0.5, for example, of myopia?
Because these are all extended depth of vision lenses, the gain in near vision is better than the drop in the distant vision.
Right.
So in spite of being 0.5 diopters or 0.75 diopters of myopia, they generally end up in a sweet spot of about 6.9, 6.6 past vision. So bilaterally implanted these patients oftentimes, have a 6.6 and 8 vision in one eye and a 6.9 and 6 vision in the other eye, and then they are able to get away without glasses. But what about the dysphotopsia profile? Oftentimes we resort to these EDOS apart from instead of the trifocals, because we believe that they give significantly less dysphotopsia. What is your experience with the Vivity for you?
So I do see that patients, dysphotopsia complaints are obviously much less. They're not gone away completely, and occasional patient will complain of some dysphotopsias, but they are remarkably less than our patients who are with the multifocals or the trifocals. And in fact, I'm seeing a big shift in our practice, where we easily offer patients EDOFs now, as compared to spending a lot of chair time and then burning your hands with the multifocals. Of course, the near vision is nowhere close to what you can get with the trifocals, but that occasional patient with the trifocal who gets those visual symptoms which are troublesome at night, the EDOFs definitely are way better, all the EDOFs for that matter, and Vivity also is in that same category. So what about you? Are you seeing any patients complain of nighttime glare and halos with the Vivity as compared to the Panoptics or the other lens?
I won't say that they have no complaints at all, but it is significantly less than any trifocal, whether it's Panoptics or any other, extra continuous range of vision lenses. It's significantly less. So you can implant these lenses without great conversation about dysphotopsia. So that's the reason that whenever a patient is very keen on quality of vision and is okay with wearing a pair of readers if necessary, we resort to these lenses.
Okay.
I think I'm butting in, but it may not be a bad idea if a particular Vivity patient is not too happy with the near vision in one eye. You can plant a Panoptics in the other eye, and that would be a good combination to work on.
So mix and match works well for you, ma'am? Is that what you're saying? Yeah? Between the Panoptics and the Vivity?
Yeah.
Perfect. I think...
Excellent surgery, Gaurav. I know you have significant experience both with the, the Centurion as well as the Veritas. You keep the pressure at 30 millimeters right through your surgery. How does it work with other platforms? I mean, do you think
So
this is with the
now-
active sentry? This
Right. So I think, it gives me more peace of mind for sure, because, I am very confident of the settings of the machine. But frankly, also on my other machines like the Signature Pro and the Veritas, I am now using a bottle height of just about 40, because I do take care of all my other things, as I was constantly mentioning about, the wound leaks and everything. So even with other machines, you can actually do low IOP surgery with most of the machines, except for the very basic machines, I think. So, but of course, Centurion probably stands in a league of its own, because the chamber stability and the fluidics are are among the best in class. So I think that's where it stands out.
absolutely. And the calibrated side ports you talked about is a significant advantage.
It has added. So if you're using a basic machine, the calibrated side ports would do what's spending 60, 70 lakhs on the Centurion does for you to an extent. So
Great surgery.
thank you, sir. And we'll go on to Dr. Mayank Panthi's surgery. And thank you so much for your tips. And please stay on, sir and ma'am.
Then we have a presentation. So this is a deferred life surgery from Ophthacon. The iron used to be used is here on Penafter. I am Dr. Mayank Panthi, based at one. These are the patient demographics. It's a hard white cataract, so you would have seen a asterisk mark on the right eye, and it's otherwise the astigmatism is less. These are my chop settings for such a case. Though I'm using active sentry, but since it's a hard white cat, I'm using an IFP of 50, which is equivalent to around 68 mm of wedgie. Similarly, these are my hard settings for quadrant. And go for the video. So this is a hard white cataract. I usually sit on the superior side, make my side port in superiorly, and this is I think the right eye. Yes, this is the right eye, and my temporal incision is on the 180 degree where the astigmatism was steeper. I make my both incisions with NVR and then extend it with the 2.2. Also would be doing some trypan blue staining. Use viscoat in such a cases. And since it's an intumescent cataract, you will also see in the process of what we call as lens massage or capsule massage, which will fuse all the vacuoles, water vacuoles together, so that Argentinian flag signs can be reduced. Though this is a 60-year-old patient, but it had significant intumescence, which you can see once we do the lens massage. We have some viscoat. So the sorption technique by we'll be using sorption technique and put in HPMC under the viscoat. And now we also be doing the lens massage, so that now we are coalescing all the vacuoles which are there. And this will reduce our Argentinian flag sign. We are not seeing very well the intumescence here, but it was pretty significant. I should have got in a scan version of the same. Then nick with a capsulotomy needle. I usually do all my rexis forceps, and prefer to use Dr. Hardipurkar's rexis forceps in all my cases. So now you see the degree of fluid which is egressing out. Also, the rexis initiation was from the wound towards the opposite side. So we end up having a C-shaped capsulotomy, let us say. So that also helps us reducing the risk of Argentinian flag sign. We're attempting to have a 5.5 mm of exercise. We'll infuse viscoelastic as and when required, because the intumescence may delay at any point in time. So we'll be infusing more and more of visco. This is our Suhas Abdipurkar capsule access faucet. I think these are made by Epsilon and these are very well handy. With a 2.2 millimeter incision, they can have very good penetration. I actually don't require any use of micro access faucets because of this, because my access is from a 2.2 mm incision. These are unedited videos, so they are taking the time I would have taken during the surgery. So please bear with me. So that will be the end of rhexis. Second thing is, since it's a hard cataract, white cataract, I would not be doing any rhexis, any hydro procedures beyond this. I will be straight going on for a chop. That is a direct chop. First, I will show you the chopper which I use for regular cases, and then the chopper which I will be using for this, which is a bigger chopper than this, which is called Amar Agarwal chopper. These are my regular chopper. So this will go out and come in Agarwal chopper, which is slightly bigger, bolder, and more thicker. So this looks a bit menacing, but it does its work well. This is a hard case, and I would start my direct chopping using active centric fluidics with the Ancon machine. It helps you because the IOP measurements, and this is my first chop which is happening. I could get a first chop, I assume. I could not. See, the lens is also moving despite having no hydro dissection there. The chopping was a bit difficult. I think I got a quadrant chop done. Such cases we have to be very gentle and take our time, especially if you are going to present it next day to your live surgeries. And also have to implant a lens of panoptics nature where you can't have a second patient ready for the same, or you can have a library for the same. So now my first chop is almost complete. The rest of the choppings will follow, but I would shift to quad mode at this point. IOP settings would be around 50, which is 68 mm of mercury, which is pretty low for such high flow cases. The vacuum would be around 500 and flow rate would be around 48. So after making a few smaller pieces, we'll take a small piece and start emulsifying the lens. Luckily the patient is pretty cooperative. It's the surgery under topical anesthesia. There's some fibrosis or fibrous additions of the lens which is not allowing it to come out. Now my first piece is out. Now you can see that my Frico handpiece, Frico tape is almost at the plane of rhexis. Since white cataract, we need to keep on infusing viscode to reduce edema. The second dose of viscode goes in. Usually I've trained my staff to tell me whenever CDE, that is the cumulative dissipated energy, goes beyond 5. So at every point of 5, they will tell me that the CDE has gone 5, because I won't be monitoring that. And at that point in time, I would stop my surgery, go in viscode again, and restart my surgery. now I have reduced my chopper length. Now this is a standard chopper which I use because now my choppings are completed. I don't want that big chopper to be there in the eye. But despite low IOP of 50, kindly observe that there is not much of fluttering in the chamber, or the AC is pretty stable. As we start towards the end of the cataract, now we start our surgery to be more superficial than being in the bag surgery, because here we do not want any mishap happening, because there is no cortex left over to support any underlesions. But slowly, but the surgical white cataract is now coming up towards the end. You won't find much of cortex left there, but we'll do a small amount of IA and inflate some amount of the bag again, just to keep my posterior cone behind, and so that I can take out this smaller piece, which sometimes can be the cause of difficult conditions. So we are slowly finishing off the last pieces of the cataract. Last few seconds are much more superficial than the capsular plane. Not much of cortex is left, but we'll do some degree of cortical cleaning. It's a bend tip which I use for IA, irrigation aspiration, coaxial, and we can do subincisional easily with this. While my blunt chopper would be holding my main port, the side port. Prepare the lens after this. Usually I don't prepare my lenses, but for presentation, Chinese do a bit clumsy loading of the lens. This is a panoptic panoptic lens, and with this new material, and 88% of light not getting wasted, but being utilized for vision, makes the clarity and dysphotopsias reduced. Since dysphotopsias are there, we are aware of that. That is why we do ask regarding the profession and nighttime driving. But with newer modification of the same lenses and higher lens penetration, we assume panoptics will be our choice of lens. You can see the rings on the surface, which are around 14 rings, non-apodized rings, which is on this panoptic platform. the viscose which we have injected, and then under the lens visco remover. Go under the lens, remove the viscoelastic. This I find much more easier with a coaxial platform rather than a bimanual platform where I would not be very comfortable, I assume. So the centration check is done with the lens, the two Purkinje images which we see, the triangular Purkinje images in the center. Once the centration is confirmed to the pupil, we can now start to close the case, do your wound hydration and wound titration. So this surgery ended up to be a bit long surgery for me, but then the case was also a bit on a harder side, as well as I had to show it today as well. So these are wound hydration, and then we'll titrate our wound with the air bubble. We'll just put some moxie and an air bubble to titrate the wound. So this is a step which I always talk to my consultants about, that once we are putting in an air bubble, I make it a point of not only pushing this air bubble towards the wound so that posterior lip of wound is also pressed. Like now I am pressing the anterior portion of the anterior lip of the wound, and after that I push the air bubble towards the wound so that the posterior part of the lip will also get like this. Now the posterior part of the lip will also get opposed to the anterior part. This helps us especially in cases where patients come back to you with foreign body sensation. So after this change in our small technique, we have found that patients post-operatively don't have phantom pains of foreign body sensation, or now have much reduced phantom pain of foreign body sensation, which patient comes after a month that everything is good, but I still have foreign body sensation. So I thought it was not a very well hydrated wound, so I hydrated again and then possibly close the case. Thank you, EKSOS and NZSOS for the submission. Right.
So any questions, Dr. Mittal sir? Any questions on Kapil?
You do this air bubble compression in each and every case?
Yes. This is my ending procedure is there, which is always there, because अगर आपको फॉरवर्ड बॉडी सिचुएशन वाले पेशेंट्स इसके बाद बहुत कम हो जाते हैं, जो एक रेगुलर कंप्लेंट होती है कई पेशेंट्स।
But
आप जैसे डॉक्टर गौरव को उसकी भी चेक करते हैं, हमारे पास नहीं है, so we do it this way.
ये तुम्हारी OCT है। नहीं, it's good. It's a good procedure, I think, and not many of us are doing this. Sometimes we inject the air just to see that if there is a little bit of detachment or something else for that, but not in each and every.
So the aim is to oppose the anterior posterior lip so closely, so that wherever the nerves have been cut, possibly they join back together, rather than both having a bulbous phantom pain kind of a neuroma.
Also, Dr. Mayank, you use the long chopper with a longer tip for chopping. So I want to know from Dr. Kapil and Dr. Gaurav, like what is the, you also do the same with the long tip? Or?
In the last 10 years, I have not used any chopper. I have only used the dialer. The long dialer, not the small one, but the long dialer, only the dialer I use. Any type of
Same.
case.
Basically, long instrument is what you are using.
So I also use a very small chopper and I don't change it for my grade of cataract. It's, as Kapil said, it's slightly longer than the dial-up, but it's very atraumatic because I'm always scared about going and breaking the rexes or something. So I've managed to do it. And I use, see, for example, you use the sharp and slightly longer chopper. I use that other technique which I spoke about in the morning, the woodpecker technique, where I just engage it with the chopper and give a burst of phaco, and it allows you to crack even the hardest of cataracts. So I think the principle is basically even Mohan Rajan sir uses a very very sharp and long chopper, very similar to what you are using. So Rajan chopper is also very much like this one. But I think in very hard cataracts maybe it makes sense.
To
It's
engage
just that
the
I
lens.
think I'm lazy and I just somehow manage with my own chopper and I don't switch my chopper.
It makes sense in hard cataracts, but somehow or other we are used to of it. So just making a little bit more 3 to 4 sculpts in the center, making it well, and then chopping is easy.
In fact, I was surprised, and you'll be
So the
surprised to know.
surgery CD was 13.5 in this case.
Yeah,
13.5.
yeah. No, it was a beautifully done
It's a
surgery, and
beautiful
in the end, your cornea was perfect. And okay, one question that was coming to my mind while you were operating, it looked like almost a totally opaque kind of a cataract. So, what biometry was possible in this?
So I had told that the biometric manner, there was an asterisk mark on the. So we had done an immersion
Okay.
and then used it to Iron Master to get it.
To get it, to tweak it. So, I'm always very scared about these patients who have a mature or a opaque cataract where you don't get a optical biometry reading, or maybe sometimes it is just kind of finding a way of giving you something, because when you are using a trifocal or something, the scope of error is very small. So whenever there is a patient who has almost a white cataract and coming to ask me for a trifocal or similar, I somehow trying to dissuade them and go for an EDOF, because the tolerance of the EDOF is very good for even small myopic or hyperopic refractive surprise. Suppose you have a 0.25 or a 0.5 hyperopic or myopic surprise, they will tolerate it well either way. So I was just wondering what you do about it, and I think you did the right thing by doing immersion.
So we do immersions for all my white cataracts. Initially, before I had an Iron Master, I had a Tommy. So the machine needs to be calibrated over time. I think Iron Master calibrates it on a daily basis, but the Tommy does not do calibration on its own. Means an engineer has to come and calibrate it for you. Once that is happening, like the machine is there for a year or 2 or 3 with you, and the calibration part goes off when you start having surprises. Because even with hard white cataract, it will give you a data. And if you go with that data and operate, you will have a surprise. So we found that thing happening with us, and that was one of the reasons why we changed from Tommy to Iron Master, when the self-calibration happens on a daily basis.
So now Alcon has to convince you to get Argos for your white cataracts.
At present, I have Tommy and I have Argas, both, but still in hard cataracts or in the white cataracts, I definitely confirm it with the immersion.
Absolutely.
So that is when we are having surprises, when learned key immersion is important.
Yes.
So wherever every machine gives you a signal to noise ratio, but that SNR value changes with machine not being calibrated over time. So initially with Tommy we were thinking 3 SNR is where we go for immersion. Now when we were having surprises, we found even 10 or 20 SNR was having a surprise. Meaning by now the machine is having higher SNR ratios and it's not doing that well. So at that point in time we started doing immersions for all the cases which are white. Even with Iron Master, reading which is correct, or especially with the exclamation mark readings which shows that there is something not so good, we cross confirm it.
Even Argas needs daily calibration.
These machines should be doing by default. I think Iron Master does it by default.
Yes. And I think what you said is what we are also doing. So we have 3 optical biometers, and we take, because then if all 3 are corresponding, then you don't have to fall to immersion. But if suppose they are not getting a reading at all, then you have to do immersion. So that's Thank you. Thanks, and I think we'll quickly go on to our last talk of the Alcon session. So I'll request Saurabh to. After this, I think we have a talk for one BVI surgery, and then we have the non-sponsored session, and then we have a group session. So lots of new things coming up, lots of exciting surgeries coming up after this. We have silk, and we have clear, and we have IPCL, and we have a VR surgery for now.
So thank you so much, and welcome all to corbet. And I won't bore you with the very long VR surgery that you might be fearing, because I I'll just show you, a video. I mean, maybe it's a collection of 3 videos for the same case, and where I will show how technology is helping us, kind of with our surgical requirements in VR at least. So I've called this Road to Redemption. So this is a very high myope with a retinal detachment. Other eye buckled several years back by me, doing well, and you can see that in this eye, right eye, it had choroidal detachment. And this is the system that we use, again, no financial interest, which is the Artivo, and we are using the Constellation. And this is a 3D visualization system which I'm using here. And we do all these surgeries in with MIVS, which is the micro incision vitrectomy surgery system. I prefer the 25 gauge. And this is the 20,000 cuts per minute which I'm using in this case, which is the hyperweight, which has its advantages with very less traction on the retina because of the sphere of influence, which is very small, as you will see how I'll show it in this case. And you can see that here, of course, I'm starting with the core vitrectomy. And you can see how mobile the retina is, but it will not flutter much because of the hyperweight. So the 20,000 cuts per minute ensures that I can safely remove even the last bit of the vitreous, even for the peripheral vitreous base dissection. And now I'm doing the retinotomy and doing the SRF drainage. And after the retina is flat, under air fluid exchange, I'm completing the endo laser. And patient also had peripheral lesions, and you can see the good encirclage effect, and finally injecting silicone oil. But this is not the end of it. This is post-op day 1. Patient was doing fine, but patient came back with a macular hole. So he had a myopic, myopic traction, and ended up with a redetachment through the macular hole few weeks down the line. So you can see here a macular hole retinal detachment. So patient I took up for revit with PFCL. So I'm doing a fluid air exchange here and draining again the posterior pole fluid. And then I've moved on to the contact lens, and I'm using this Finesse tube, which is very atraumatic. Again, no financial interest, but it is a very good nitinol loop. But here, since it was not working because of the retinal attachment, I'm doing under PFCL. I've stained with brilliant blue G, and I'm putting the ILM plug over the macular hole, because in this case it is critical to close the macular hole if I have to achieve reattachment. And now I'm doing SRF drainage. PFCL is still there holding the ILM plug, because in these very high myopes it's critical. And now I'm injecting the silicone oil at the end of surgery. Patient did well initially, but again the bugbear, it comes back again. You can see the SRF building up, although the plug is still there. And now the third surgery is a redetachment at the posterior edge of the buccal, and you can see I'm removing the membranes here which have formed, which is very common in these patients, high myope patients with choroidal detachment. Very patiently, with a tug of war and with other maneuvers, I'm trying to release the PVR which is there and is causing this recurrent retinal detachment. And finally, going on to air fluid exchange and doing endo laser. So since this was an inferior PVR, I have put Densiron in this case, and finally after using Densiron, this patient remains settled. And this is the last picture post Densiron removal. Patient has a vision of 660, and you can see that the ILM plug is still there over the macular hole, and lot of laser CRA in the inferior retina. So the retina remained attached, and it was important for this patient. This patient, by the way, also had advanced glaucomatous changes, to kind of make the situation more complex. So this was the tale of the high myope retinal detachment with choroidals, with almost like a glaucomatous, advanced glaucomatous cupping in both eyes. Other eye already buckled. Thank you.
Dr. Saurav says such an excellent series of surgeries, complicated case, but that Densiron, just tell me something about Densiron.
So basically it is heavy silicone oil, and it is used mostly for inferior PVR. So it is made in such a way that it kind of, so silicone oil it's light, so it has a tendency, the normal 1500 centistokes oil that we use, it has a tendency to rise inside the eye. But Densiron has been made in such a special way that it settles down, and it tamponades the inferior retina more. So whenever we have inferior PVR, especially in such high myopes, then Densiron is very useful to prevent retina from detaching in that area, and has a good tamponading effect on the inferior retina. So that is the special thing. It is an expensive thing which now actually it's being marketed in India. They've started marketing it in India. Earlier they were we used to get it from abroad, and it is used for select cases of inferior PVR.
How is hyperwit different from what we were doing like maybe a year or two back? What is different?
So the thing is that the earlier versions, we've seen the evolution of the cutter. I remember when I started doing my VR surgery, it was 750 cuts per minute. So that is the time when we used to use Storz Prodigy that was my first vitrectomy machine actually, and that was not even a posterior segment machine. We were just using the cutter function of that. And but then it has evolved, and earlier before this we were using 10K cutter for quite some time, which was quite good. But the good thing about the hyperwit, I'm sorry I couldn't include that part of the the slides, but the hyperwit one, it is a beveled kind of instrument, a beveled vitrectomy cutter, and where the tip is closer to the the opening is closer to the tip, so it can go into nooks and crannies, and it can remove membranes, and you can do so virtually. It does the function of all the multiple vitreoretinal instruments that you have, and you don't need to exchange so many instruments to do various functions. You can use it as a cutter, you can use it as a scissors, you can use it even as a forceps with suction. So it works very well in nooks and crannies, and and the 25 gauge again makes it even better.
No, but why does it cause less flutter of the retina, which is
so
mobile?
20K means it is 20,000 cuts per minute. So basically we were using 10,000 cuts per minute, now it is 20,000 cuts per minute. So you can imagine if the cutter, the guillotine action, it is. So another advantage of the Alcon cutters is that both the movements are active. So if you remember from your earlier days, we used to have active movement, and the recoil was passive. But in this case with the Alcon cutters, the new Constellation cutters, both the movements are active. So the to and the fro motion are active. So very carefully you can control the amount of traction. So because of what I said was the sphere of influence. Why we call it the sphere of influence? When you are working close to the retina, with the smaller gauge and with the hyperwit, the traction on the retina is minimal because it only acts in a very small area around the tip of the cutter. That is the area where the vitreous will be cut without putting any traction on the retina underlying it. That is why the hyperwit is a very good way to go about things, especially also in diabetics. It is very helpful in diabetics.
Thank you so much, Saurabh.
Thank you.
And we'll go on to our next talk. Do we have on Zoom? We should be having Dr. Ajay waiting on Zoom. He couldn't make it in the morning, so his talk had been kept for. Can you please check on Zoom if we have a link?
Would be really obliged, Gaurav.
Oh, sorry. I thought you had left, ma'am, because we are not seeing you on the screen.
No. I think the voice of all the speakers is very muted. So all of us who are on the line, we can't hear much at all.
Oh, I'm so sorry. So, but ma'am, any...
Now it is better.
All right. So, any comments on that last surgery from you or sir or anybody else who would like to chip in before we move on to Dr. Ajay Sharma's talk? I can see Dr. Ajay also is already online. And we'll try to improve the audio. Audiovisual team, can you please do something to put better audio into the Zoom, because they cannot hear us. There's too much of echo. So please find a way that our audio goes to them in a better way. Any quick comments, ma'am, before we move on to the next surgeon?
A wonderful surgery by Dr. Saurabh, and how he managed to show different situations, and at the end gave us so much points to understand. Only thing, we felt bad that we could hear very little. Congratulations, Dr. Saurabh.
Thank you, ma'am. I think we'll move on to our next talk, and if you're still going to be around, we would love to have your comments. So Dr. Ajay Sharma from the IQ Hospital in Gurgaon is going to be operating on a patient, and I would love to hear, welcome sir, and he's just landed back from abroad, I think, so he's still probably jet lagged a little bit. Please go ahead, sir.
Thank you, Gaurav, and thank you, North Zone and Ophthacon Society to invite me for the deferred nail surgery. Today I'll be operating upon a 67-year-old male, where I'll be implanting a DVI fine vision IOL, and she's okay. I hope I'm audible properly and my screen is visible.
Yes, yes, perfect.
Okay. So I normally do femto in all my cases, and I think if not all, around 85% of patients. So that is why I've been showing it. So this technology probably will next session we will be talking much about it. The only thing here which I wanted to show are these two marks, because it's a toric lens, and for the toric lens this mark here. So for the toric lens the marking can be done on table while you're doing a femto itself, and once the femto is over, uh, so this is the patient which will be operating, and the marks have already been put by the laser here and where the lens is to be positioned. Now post it seems it's like a 3 plus grade cataract, and phaco and all, I think we all are expert, we do everything now. The thing is more talk about the lenses. Nowadays the most important aspect of anyone's life is the intermediate and the near vision. Distant vision we have been giving to most of our patients ever since we started phacoemulsification. This is a triplanar incision I'm trying to do, and so there are so many lenses available today from each and every company, but this is a trifocal lens which gives vision for all the three distances, whether it is a near, intermediate, and distance. So it gives a continuous range of vision, and is an excellent lens. I'll just show you that. And this lens is from DVI, and this was the world's first trifocal lens. It initially used to come with a different trade name, and but the loading and all is simple. Surgery, again, we are taking the cortex out here. I think they'll be talking about it, but once the femto has been done, the cortex removal is a bit tricky because you have to go underneath the rexus and here like this and take the rexus out. So I normally use a coaxial, and even all my cases, but definitely at times when you struggle you need to take it to bimanual, and the little bit of polishing always. For that I recommend spend at least a minute. There is no hurry because post-operative result will depend on the polishing what you have done of the capsule anterior and even whatever posterior capsule is needed. So now this is the lens which is a this is, yes, can you see, this is the lens. This is a double C loop, and you can see there are these two eyes here, holes here, the front leading haptic, and then the on the right and trailing on the left, and these are the rings. There are around 26 concentric rings here, and which gives a good vision, and there is a this is a convoluted and apodized design with a spheric surface. This is how you just do the loading of the lens in that cartridge, and very nicely it goes in. It has four haptics, so there is no chances of you know movement inside the eye, very less chances, and amazing for a toric lens because the stability of the lens because of these haptics are is excellent. And the normal average rotation, what the studies have found, there is around 1.22 degree average rotation is there. Now it has a add of 3.5 diopters for the near and 1.75 diopters for the intermediate vision. Just one trick while you are implanting the lenses, because it's a the four haptic, you just go in there while you are putting the lens, and when you are pushing the last bit, just put your cartridge down toward the center of the posterior capsule. Look here, I'll do that, and just go down, and last I bend it down so that these haptics, they open inside the bag, because at time it can cause problem initially if the surgeon is new, because these haptic, they can engage in the iris, and they can cause a little problem. And but again, you should know how to put the haptics inside the bag. And yeah, so the double C loop design is very good, as I say, and so this will be positioned in the area where I want on the axis, wherever is required. Now, good part about this lens is that since it is double C loop, we can dial it either way. Either you can dial it this way, you can dial it anti-clockwise, because this is it is not a C loop lens. So this is a very good thing. At times when you even I feel that even you have 1 or 2 degree away from your desired axis, then it's best to dial the lens to, and so either we go a full 270 or we dial it either way here. So that is something is very good in this. So yeah, that's it from my side. We have been using this lens now ever since it has come, and I think maximum number of series we have done a lot in our organization, and amazing results. And the halos and glares are there, but it is not. I have not seen patients who come and say, okay, fine, I want the lens out. Whereas in others, we have seen the patients scribbling a lot, but here I have not seen such thing. So that's it. Thank you. Any questions?
Thank you, Dr. Ajay sir. And that was a beautiful surgery. And of course, this lens is on the BVI platform now, but we were using it even an older version of this lens. I think we were using with the fine vision. And that fine vision lens used to come a few years back. Even that used to be excellent. It used to get excellent results. And now I think with the new lens, with the BVI platform, this lens has become even better. And even I have used a few of these lenses, and they seem to give very good patient outcomes. Anybody else here who's using this lens, Dr. Kapil or Dr. Pankri? And sir, do you see a shift? I asked this question before also. Do you see a shift a little bit from trifocals to EDOF lenses as far as the patient choice is concerned? In your practice, are you still doing as many numbers of trifocals as you were doing before as a percentage? Or have you seen more EDOF now than trifocal, because sometimes your patients are wary of the halos, etc.? Or do you still see a good demand for trifocals and lenses?
So I'll say as of now the demand is equal 50-50, because many patients, they want near vision also. All the EDOF lenses, and which mainly I use as a 4C or the smart one. So the near vision is compromised definitely, but it's not that yes, the shift people are going towards the EDOF lenses again. Everyone is worried about the halos and glare. So this is something, as surgeons we are worried, and as patient become they read everything, and then they come, and then they have their younger either kids or grandkids with them who tell them about so many things about these. So yes, it is shifting, and but that's for good, because we see so many lenses coming in, and they are giving extremely good results. And you just talked about Purity, I heard about it, and I think someone will be talking about Purity. So that's amazing thing.
Yes, and I think a little bit of it is just escapism, because we don't want to deal with the halos at all. So maybe as surgeons we are finding it very convenient to shift patients to EDOF lenses. Whereas I think also with the trifocals, the quality of near vision that you get, you cannot get with any EDOF, frankly, because that true spectacles independence which comes with the trifocals, you can't really get with any kind of EDOF lens. So that's another thing to keep in consideration. If a patient really wants excellent near vision, then you have to give them a good lens, something like this one that you showed from BVI. So thank you so much, sir. And I think unless there's anything else you would like to add, we would like to move on. Is there any other point that you would like to make on for your surgery, or for the new technology lens that we just saw from Fine Vision?
I don't hear you.
Any final comments, sir, on this?
Okay. I think move with the time, that is very important, and EDOF lenses are definitely here to stay, but we can't rule out the trifocal lenses, because demand for near will always be there, unless and until we get EDOF lenses which can see around 33, 35 centimeters, and these are glistening free lenses, and so the results are very good, and yeah, that's it.
So thank you, Dr. Ajay, sir. I think we'll move on to the next session, and thank you for joining us in spite of your tight schedule. We'll go on to our next talk, which is, I think it's our next session itself. And can we have the next session on, please?
We have a non-sponsored session, and the chairpersons for the non-sponsored session are Dr. Chitra Ramamurthy, Dr. Kirti Singh, Dr. Kapil Agarwal, Dr. Sanjeev Hansaraj, Dr. Reena Chaudhary, and Dr. Charu Mittal. And the first surgery is by Dr. Anshika, that is, she will be showing us sync. Dr. Gaurav Nutra will be showing us challenging cases with flax and enhanced monofocal iron. Dr. Kumar Gaurav, doctor, and Dr. Tushar Om Prakash. Dr. Anshika Luthra is online, and let's have her say. Welcome, Dr. Anshika. Can you hear us, ma'am? Hello? Dr. Anshika, you are muted.
Oh, yes. Hi.
Can you hear
I'm
us?
sorry, I didn't. Yes, you're audible.
Good. We can see you,
Yes.
and
Okay.
you can.
All right. Shall I start?
Yeah, welcome to NZOS and UKSOS meet. Let's start.
I'm sorry, your voice is a bit muffled, so I'm not able to make out all of it.
Okay, welcome, and let us start first.
All right. Okay. Thank you so much to North Zone for having me here. And I'll just share my screen. Is my screen visible?
Yeah.
All right. Thank you, ma'am. Okay. All right. So I'll be showing it. Is it visible?
Yes.
We can't see
All
your
right,
screen.
so-
No, we can't see your
We can see you.
We can see you. We can't see your screen
You
yet.
can see me.
Yes.
Okay. All right. I'm going to stop the share and start it once more.
Yeah, just the problem is
What about now?
sharing.
Can you all see now?
No, we are seeing you, The
I
screen
think
of
somebody from the conference needs to change the view maybe, but I've changed it to this view.
We can see the screen, huh? Anshika and Dr.
now we
Kumar.
can see a
Yeah,
small
no,
screen.
online we are able to see.
Online it's
But
fine.
we did see
Offline they
my
have to be
video
able
as
to
well.
see.
We are seeing your screen bigger and your
Maybe somebody from the conference can shift from the presenter view to the other view because online the screen is playing. Yeah.
But just now they saw Dr. Ajay's video, no? I don't know why.
Yeah. 1 second. Okay, how about now?
we are seeing your screen as well as we are seeing you, but we are seeing you on a bigger picture, whereas your main screen is on a PIP mode.
Sorry? I'm sorry, there's a lot of overlap, so I'm not able to make out.
Yeah, it was visible in between, so why don't you try again?
Okay. Is it visible right now?
No, it's not visible.
Okay, alright. So I'm going to share again. And
Yeah, it's so now it's okay.
Perfect.
alright, great.
Now it's
Okay, so we'll start with thank you everyone for helping me out. We'll start with the pre-operative details of the patient. It's a 26-year-old female. She has a stable refraction for the past 4 years. She has a compound myopic astigmatism, and on doing a peripheral retinal exam, we saw that she had lattices in both eyes. She underwent barrage laser for 2 weeks ago and was cleared by retina and then taken up for silk biopsy. And her pentacams are clean. She has a good pachy, and anterior and posterior elevation float is all well within normal limits. So we have planned this procedure for her, bearing that in mind. So before we start, we want to enter the treatment plan, which includes the demographic details of the patient, and secondly, okay, so we enter the demographic details of the patient, the corneal thickness, and we choose whether we want to go ahead with a flap or a silk. And in this case, we've chosen silk. And moving on, we enter the refraction of the patient. Along with that, the spherical and cylindrical adjustment as per the nomograms, and also the keratometry values, which help the machine to recalibrate when the optical zone gets altered during applanation. Next, we have the energies, which are customized to every machine based on the glass burn threshold. And we have the entry width, which is 3.5 mm in this case. We have something called the flat add, which is a non-refractive add in the thickness of the lenticule that we do. In this case, we've chosen 15 microns. The role of this is to normally create a lenticule that is easy enough for us to separate in size. And the optical zone is 6.2. We can generally keep it between 6 to 6.5. We're opting for a standard 110 cap thickness in this case. And with this, we can see that for a 6.2 optical zone with an 8.2 transition zone and an entry width of 3.5. The thickness of the lenticule in this is 103 microns, and it's giving us an RBT of 327. So now with this, we can start with the procedure. And the first part of that would be the assembly of the patient interface, which for the Elita is a two-piece, one being the cone and the cap, the protective cap that comes with it, and the second being the suction ring along with the suction connector, which is connected to the tubing. So we are placing the cap now and the cone, and we're removing the cap once it's fully inserted into the gantry, and then connecting this suction connector into the machine, which will allow for the vacuum to build in the suction ring when we place it on the patient's eye. And after this, we do the PI scan, which ensures to account for any tilt or any manufacturing variations in our PI, and a uniform laser firing. Next, we place the suction ring on the patient's eye. So it's very important that before we do this, we have to clean the meibomian secretions of the patient thoroughly to avoid any irregularities in the laser firing, and also to moisten the cornea. It shouldn't be too moist and it shouldn't be too dry. After that, we make the patient fixate using a finger, and we ask them to look up, and using the pupil center as our center, we place the suction ring, and then the assistant can turn on the vacuum. So here the suction ring has been placed. Now we go ahead with docking. So in docking, the gantry first moves down, and once the vertical pressure is adequate and in the green range, as we can see, then we have to gently pinch the grippers that are present on the suction ring that allows for this meniscus to form, as you've seen. Then we have to move down a bit further, and then using the gripper clips, we increase this meniscus size, and it should go beyond this 10 white ring that we are seeing. And then we know that it's adequate. So once that is done, we can lock it. And after this, we can do a post-docking centration, which is unique to this machine, in which we can center it to the pupil center that we had marked earlier and the 0 and 180 marks that we marked preoperatively in this patient. So this ensures that even after applanation, if there's any variation, we can alter it. So the treatment occurs in a raster pattern, proceeding with the posterior plane first, then the ring, then the anterior plane, followed by the entry. So this has a contiguous submicron laser firing, which is supposed to be very precise. And it also has a fast blanching technique, so that prevents any redundant laser shots from being fired in the raster pattern. So once this is done, we undock, and that's it for the laser procedure. Now we simply remove the lenticule after dissecting it. So we take the patient under the microscope, and okay, so before we start dissecting, just ironing out a bit of the OBL for clarity, and then we can enter through the entry wound. We're using the Schroff dissector in this, and so when we are entering through the entry wound, we demarcate the length of our incision. So this helps us know how far we can go during our dissection laterally. And after that, the critical thing is that when we are entering into the anterior plane, we have to tilt upwards. So this is what differentiates it from a smile surgery, because in smile, you would naturally enter into the anterior plane, but in this, you would effortlessly enter into the posterior plane because of a biconvex shape of the lenticule. So first we've entered into the anterior plane, posterior plane, then we see the stop sign in between, and then we proceed with the dissection of the anterior plane, starting from the center and proceeding to cover out the anterior extensions on each side, finishing one side first and then moving to the other one. And similarly, then the posterior plane dissection, we start paracentrally, then complete one side, and then move to the other side. So I think the most critical step while dissection is that you have to find the anterior plane in the beginning, because sometimes you can enter the posterior plane on both sides, and then later on it can be a challenge to find the anterior plane. But once that's done, it's very smooth. And then we can go in with the forceps and push the lenticule edge so that it bunches up, and then we can grasp it and we can take it out. We can check to confirm that there are no tags, and then if some people can iron it out towards the incision site, and that helps with smoothing it out. And that's it.
Very nicely done surgery, Anshika. I hope I'm audible to the audience.
Yes, ma'am.
And when she started off and she had docked, I felt that there was quite a lot of OBL. I even wondered whether the cornea had got dry or what. But the way she smoothened it before, cleared that OBL, and then the way she's done it, it is just like a textbook picture of how a lenticule extraction has to be done, and very nice.
Thank you, ma'am.
The other question to the any other panelists who are using silk procedure, have you felt the need to titrate the energy a little more carefully in your earlier cases to get a better visual acuity post-operatively? Anshika, you have anything to say on that?
Yes. So, ma'am, as we know, so the titration is highly machine dependent, and for every machine, they have a unique glass burn threshold based on which they optimize the energies. As we could see in this case also, that there was an air bubble that had appeared in the anterior plane in the center, and that is a sign that we can reduce the energies a bit further down. But we have to take care not to reduce it too much, because then that can result in resistance when we are dissecting the planes. I don't know if anyone from the panel would like to comment upon it.
So I think Dr. Chitra ma'am has experience with 3 platforms. She
Yeah.
uses the Visumax 500, the 800, the Silk, and she uses the Clear. And she is
Yeah.
best equipped to answer this question, that how does she find, the energy comparisons between the 3, 4 platforms. And I think I see Gitansha also there, and she can chip in too.
Yeah. Yeah. No, I think it is all, each machine has now, overcome all the earlier limitations, and they are all pretty optimized. We just need to do some n number of cases and look at the visual acuity post-op and titrate the energies even on the anterior plane and the posterior plane, posterior cut, and identify that. And then I think once it sets you off, it goes good. So that is all there is. I think every machine in the right hand, whether it's Clear or Silk or Smile, of course, has had a larger innings, but then everybody is doing very well.
Dr. Chitra, I have a very interesting question which our audience might be interested to hear. That if a straightforward 25-year-old myope with say -5 or 6 of myopia and couple of maybe half to 1 diopter of cylinder walks in and has good everything, good topography, good, best corrected vision, and has good corneal thickness and everything that goes with it, and you, since you have access to almost all the procedures and also all the excimer procedures and maybe Wavelight Plus and everything on Contura, what would you be your first choice of treatment to the patient? Like what would you
What-
what would you
What
be
was
most comfortable offering?
what was the cylinder you said?
I said half to 1 diopter of cylinder with -5 or 6 of sphere.
No,
So
no.
what would you choose to offer the patient as your first choice, and why?
See, if the corneal thickness is adequate, I would never even think of suggesting anything but a smile procedure for them, because the procedure is done in no time and the vision is just clear 6/6 the next morning. So that would be the only choice. Only if you are looking at a significantly high cylinder where the sphere and the cylinder are nearly equal, or in those kind of situations, I would even consider, why not look at femtocontura. Although I would not, with the latest Visumax we can correct any high cylinder effortlessly. But it's just that because you have different gadgets and each of them are so promising, so the cylinder is quite high, we would look at femtocontura. And if the corneal thickness is less, then we would comfortably explain to the patient to get a PRK done, and accepting for that initial minimal discomfort 1.5 days. At the end result, at 6 weeks, all of them do well.
So that makes it quite easy, because there has been a huge shift towards lenticule. Anshika, in your practice there at IQ, are you doing more lenticule procedures now, or still more excimer procedures?
So for patients who have a good amount of spherical correction and a relatively smaller amount of cylindrical correction, we are preferring Silk. But for patients who have more of a high astigmatism and not so much of a spherical error, we still go for LASIK.
And
Lab-based procedures are
seen,
preferred in those. And of course, for hyperopes, Silk is not an option yet. So
also, I saw that you had some kind of a calibration going on in the beginning for the PI that you were using. What is that? Like there was something that the machine was doing. It was calibrating.
yeah, so we have a PI scan, a patient interface scan, that is very essential, because it compensates for any manufacturing variations in each patient interface or any PI offset or tilt that is present. And it does so by adjusting the trajectory of the laser that will be fired, so that the laser pattern is not affected by this tilt and variations. So that's why they have that PI scan, which is very essential.
Great, thank you. I think we'll have to move on because we have a few other surgeons waiting, and I can see Dr.
Gitansha, you want to add something?
Gitansha, you have anything to add to that?
I just wanted to add a short thing regarding high cylindrical correction, sir. So essentially, one thing that we could look at is also the correlation of the cylinder that the patient is accepting with that of the tomography, and also the quantum of the cylinder vis-a-vis the sphere that we're correcting. So initially there was a tendency in which the cylindrical power was a little high to go in for a flap-based procedure. But I feel with the advent of these newer platforms like even the Clear or even the Visumax 800, they do account for the cyclotorsion compensation. And I've even published studies of Smiles contralateral eyes wherein we did a manual cyclotorsion compensation in one eye and in one we didn't. Essentially, both eyes did equally well. So it's more important when the cylinder is more than 1.5 or the cyclotorsion is more than 15 degrees. But with the newer lenticule-based platforms, with the cyclotortion compensation, I think even for higher cylinders, the results are equally good vis-a-vis flap-based procedures.
So Gitansha, one last question before we move on.
Yes, sir.
What kind of a space do you see for newer excimer technologies like Wavelight Plus and all, considering that there has been a huge shift towards lenticule for all the practical reasons that it provides so much of safety for the patient and for the surgeon and peace of mind, and quicker rehabilitation and good 6/6 vision post-op. So where is the room for still flap-based procedures which are improving upon themselves with the newer excimer technologies?
I'm sorry, sir, where is the room for?
What kind of a room is there for newer excimer technologies which are promising better visual outcomes? For example, the Wavelight Plus.
The excimer technologies, I think, at the end would have a very niche use in patients who don't have an adequate corneal thickness in the tomography, or very often we have patients who want to enter the army or in certain conditions where they actually don't want to show that they've undergone refractive surgery. Otherwise, I think excimer lasers would definitely have longer visual recovery vis-a-vis either the flap-based or the lenticule-based platforms.
Thanks, Gitansha. I think we'll go on quickly. I think we should invite some of the speakers who are waiting on Zoom rather than have our own speakers here. Can we call the next one? Yeah.
We have Dr. Kumar with us. Dr. Kumar.
Good afternoon, everybody. I would like to thank
Dr. Kumar, now we would like to welcome you. Can you hear us from here?
Yeah, can you see the screen?
We can see you and we can hear you as well.
Okay. Good afternoon, everybody. I would like to thank all the organizers of the North Zone Conference, Satanshu and especially Gaurav, because this opportunity was given by him to me. So I'm going to show you a case, a male patient, 56-year-old, has a mild cataract, but the pupil is small and has a history of prostate. And I'm going to go ahead with a foldable IOL, which is about 22 diopters measurement according to the G-scan that we've got. So I'm going to show you a very interesting step, and it's very different, and which is going to be a ring, which some of you may have never heard of or seen before. You make the incision. Maybe enough. But you need, when there is prostate, always make sure that we are sure that we don't have a problem. This people look adequate to do a safety notification.
Kumar, can you pause it for a moment? Can you pause it? Can you decrease the volume of the music background, because we can't hear you after that. So just decrease that and just the volume of the movie that is.
Okay. Now you can hear?
No, just decrease the volume of the video background.
Can you hear me?
We can hear you quite well, but that music interferes with what you're saying. So keep that a little low. Just what you're playing, just keep that a little low, and you can speak then. That'll be easier.
Okay. So this is a ring that some of you might have never seen. This was invented by Jagdeep Kakaria and R.C. Shah from Mumbai. You can see this ring. It's very different in shape. This part actually holds on to the iris. This goes below the iris, and it gives an excellent exposure. I've used all the rings today. This is my first attempt to use this ring. Not that I've touched this ring before. I opened the pack and I wanted to use it directly, and that's why I'm examining the ring under the microscope to see how it actually looks. You can see it's a very simple design. It's like 4 flowers as in one of his presentations. And you get a good adequate pupil size. That's the another beauty of it. And you see when I put it in the eye, there's a bit of a struggle. I have not edited that part of it because I am using it first time. So here I'm putting it on the eye, and then of course this goes to the main incision. I've not attempted putting it to the side port. You can see that yes, one attempt, and then a little bit of a second attempt, and a little bit of a push, and then just go on to the thing and keep pushing it inside the eye. So this is the 2.65 millimeter incision that I made, and I'm putting the ring inside. And you'll be surprised through the procedure how well it actually holds on to the iris. It's very, very easy. No struggle, nothing else is necessary. I'll talk a little about it later on if any questions. Just a finger hook, just hook it below the iris, and you can see that that covers it and it holds. Very simple. Then you go around and then you hook the other part. Make sure all of this segment goes behind the iris. You can see I've actually placed it first in the anterior chamber, got a viscoelastic in the anterior chamber. I'm putting the ring inside. And then now I'm going to the side port because that's the sub-incisional part of the ring that is now to be placed. So you can see I'm getting almost 7.58 millimeter exposure. And throughout the procedure, you will notice now again putting a viscoelastic, that this maintains itself. Yes, are you getting a round pupil? May not be. Does it really matter? There is absolutely no about you see the procedure here. This is an unedited video as it's a deferred live surgery. So doing my rexis with my forceps as usually I like to do. Once that is done, go ahead with the hydro procedure. Once the hydro procedure is done, go ahead and use it. Important to notice during just the iris flutter. So I expect a bit of flutter, but you will notice that there is absolutely no flutter. Here it's gone through. Now we go ahead once I got my hydro procedure and just go ahead and put in the bit. With the gymnastic, a bit of full perfect that we can see. Now a little bit of moving. If I like to use a sharp pitch dropper by my name, financial interest, three sizes 1.25, 1.5, 1.75. Then just hold the cataract, go around, separate, then go ahead. So look at the ring. Holding on to the iris well. It's fantastic. Flutter, you never see moving. Very strong. It holds on well. My first unedited experience of the clinic. So I'm going ahead and doing my modification and I get 2 weeks. So my bottle height and notice is 50. So the IOP is now 25, 6. That works very, very well. So I have the aspiration, the irrigation and the vacuum and the power going on. You can see on the side. Once that is done, then go ahead and do a bimanual line. Again, look at the flutter. The anterior chamber, nothing at all. This is a bimanual line, as Gaurav has told you before. Bimanual line because it's when the whole side is correctly geared to that weak at all. We can design 9 curves so that they balance out each other. But here, what we are trying to do is a new ring of the head and the speed comfort of. You can see during the bimanual IA, very, very easy to do it. Absolutely no problem. Moving at all, nothing, no movement, just stays there.
Kumar, can you switch off the music, please? We can't hear you well.
Once that is done, you can see the amount of exposure. So my CCC will be about 5.5.
Kumar, can you switch off the music?
That I'm getting a good enough exposure, about 7.5 and even 8.
Kumar, can you hear us?
Once the cortex is removed, go ahead and put the IOL in the bag. Then coming to the...
Kumar, switch off your music.
So you can see the IOL put in the bag. I like to put it on the elastic. I don't for hydroimplantation. So here you can see the lens going into the bag. And once the lens goes into the bag, now the trick is, remember friends, whenever we use the ring, I always like to remove the viscoelastic from behind the IOL before I remove the ring. But here, because I thought that the adequate exposure of the pupil is there, it's okay to go ahead and do the viscoelastic removal later. So here you can see again, this
disengaging the subincisional catch in the iris, and then going with the MacPherson. So I'm holding it, the rest of them are still there. Go ahead with the MacPherson, hold any part of it. Okay, once I'm holding it, just bring it out. And then you can see again I'm doing it to this. It's defined by me, my surgery, because this is my first attempt. Once this is out, you will see that it's completely out and everything is proper. So once it is out, then you can see the two of the other eyelids are also disengaged.
Dr. Kumar, hello?
Yes?
Can you hear us? Just
I
switch
can
off
hear.
the music because we can't hear anything of it.
Oh, okay. Now you can hear me?
Yeah, you can bring down the tone of the music.
Yeah.
Further, you can
So
totally
here the
switch
whole
it
thing
off.
is out. You can see the ring is being brought out. And once the ring is out, just remove the viscoelastic. So I've just removed the viscoelastic and that ends the case. So this was a different ring some of you might have never seen or heard of or experienced. I'll stop sharing so that the music is gone. Now you can hear? You can hear me?
We can hear you, but your music is so good that we don't hear you.
So friends, that was first time anybody would have demonstrated the Omega ring in deferred live surgery, of course, for the North Zone. I'd like to thank all the organizers. Thank you again, Gaurav, Satanshu, and the whole team. Thank you.
So Kumar, we want to hear more about the ring now that the music is off. You know, your music was so good, we were all tapping our feet, but we could hear only a little bit of what you were saying. So you can
Sorry.
tell us what is the material of the ring?
So you'll be shocked that the material is the material of the sleeve of the Ophthacon.
Okay.
So the beauty is it comes in a case. The case is autoclavable and inflatable. This ring is autoclavable. That's another beauty, and it costs 3,000 bucks.
Oh wow.
So I think it's going to be a game changer because it's very cute.
And
And
Prashant,
very-
Prashant Babankule is with me. He's very impressed with your ring. He's asking something.
How many times can we use it? Means if it is autoclavable, it means it can be reused.
Yes,
So what's the number of times you could do that?
that was
Still
my first
maintaining-
attempt.
Okay.
I think practically speaking, we could use it number of times because it is all the purpose it does is it just keeps the pupil wide. Now it's not like some of those Kahoot blades that you keep using it, the sharpness goes and you can't cut the meshua. Here there is no other purpose but holding. So unless it becomes too tight and short with repeat autoclave, I think you can use it.
And
Another-
Kumar, we saw you were using the Veritas. And how do you find the Veritas better than your older machine like the Signature Pro that you were using before? In the
I have
Fluidex or
the-
whichever.
I have
is
the
there
Ophthacon
anything-
Feroz, I have the Signature Pro, and I have the Veritas. Veritas was as good as the Signature Pro till I didn't get the AI tubing. Now because I have the AI tubing, it makes all that difference. You can keep your IOP low, does very well, there is no surge, etc. But I think once the real handpiece comes, it will make a bigger difference to the whole system. So right now, I don't think anybody of us have the handpiece. None of us have been promised when it's going to really come. So we all are living in a daydream that one day it will arrive and make the system complete. But on the whole, I think it performs very well with the new tubing.
And Kumar, one last question that if you had to undergo, I can see that you're wearing those nice glasses. If you had to undergo a cataract surgery today, what kind of a lens implant will you choose for yourself?
What kind of?
What IOL will you want to put for yourself in your eye?
You'll be shocked. Actually, Gaurav, I'm going to come to you only in the future. But the point here is I was looking at IHANS for myself. But lately I've been using a lot of lentis. So I've been using a lot of lentis multifocal, the FEM, and the lentis EDOF. know it's hydrophilic, I know it's a plate haptic, but you'll be surprised, no glare, no halos in a multifocal and they're N6. So suddenly I got confused. And if
Now
they had
whether
a
you
high,
should do eye hands or lentis. What about femtis?
it does very well.
You
I have
use
done,
femtis?
yes, and they're excellent. They never move.
But they have two models that you can use, the femtis one and the other one. What are the names?
So there's one femtis called the EDOF, that's for the normal EDOF, and the femtis multifocal.
Okay.
And that both works beautifully. You won't have glare and halos. That's the most important part. Even some of our PPT patients do complain of a ring sometimes. But these guys don't complain of anything at all.
And how much does it cost?
I've implanted a lot of EDOFs and I've implanted many, not lots of multifocals, but no complaints.
How much does it cost?
I think the Femtis cost 70,000.
70,000?
Like 25,000.
Sorry? Femtis is 70,000 and lentis is how much? 20,000.
I think 26,000 or 24,000.
Okay. So very nice surgery, Kumar. Thank you so much, and thank you for taking out time and joining us at North Zone in Corbett. Corbett Tigers are missing you. So, maybe
Thanks,
someday
Gaurav.
you'll be
Thanks,
there.
everybody.
And thank you so much for joining. We'll go on to Dr. Tushya Omprakash, who's also waiting online. And Kumar, you can stay on for comments if you have time. We'll have Dr. Tushya Omprakash from Amritsar, who's joining in for sharing his complex case. He's promised to show us something nice. So Dr. Tushya, please take over.
Hi sir, am I audible sir?
Yes, very much.
Okay, I would like to thank Dr. Gaurav sir and NZOS for giving me this opportunity. So those were some excellent live surgical demonstrations before. There was a lot of pearls and lot to learn too. So I will be sharing my screen. So today I'll be showcasing a case of a white intumescent cataract. So this was a 50-year-old patient. And what we have been doing is we have been doing a preoperative OCT in all the intumescent white cataracts. So we do it in white cataracts, posterior polars, traumatic. So especially in intumescent cataracts, it gives you an idea whether how much of cortical fluid is there. So it gives you a good idea and you can do a good planning before starting the surgery. So here, if you see on the right side, there's a OCT picture, and the black areas, they show that there are cortical fluids pockets. So I'll be starting my case. So usually when I start the case, I give a temporal incision. I give a biplanar temporal incision because temporal, it's more accessible, it's more easy when you have a deep set eye. And then of course, temporal incisions are astigmatically neutral. So I use a biplanar incision, a bevel keratome. So good staining is very important in white cataracts. So I use a modified 30 gauge needle trypan blue staining technique. So this technique has been published by us. So what we do is we inject the air from the main port. Then from the side port, 30 gauge needle is inserted into the peripheral portion of the cornea. And once it enters, and you can inject few drops of trypan blue. So it is a very good under air trypan blue staining technique with minimal drop, and you can have a good hold time of around 10 to 15 seconds, which gives you a good uniform adequate staining. And then viscoelastic, I'll be using a viscodispersive as I'm comfortable, but as Dr. Mayank previously mentioned about the tri-soft shell technique by Dr. Ashnoff, you can use that also. So as Dr. Gaurav also mentioned before about the advantage of using calibrated incisions, so I would really like to tell you about the advantages of calibrated side port as well as main port incision, because when you are using a calibrated side port incision, it's we usually do it with 25 gauge needle. So this technique has been published by us recent this year. It gives you a very good chamber stability with minimal leakage throughout the surgery. So I'll show you how beautifully, without any leakage, with excellent chamber stability, we are able to complete the case. And now, what I'm going to do here is, as I know there are cortical fluid pockets, so I'll be inserting the 30 gauge needle from the peripheral cornea and entering into the central portion of the lens. And the moment I enter, what I do is I simultaneously aspirate the cortical fluid so that the fluid in the central portion of the lens is aspirated. So it decompresses the bag. You can see here how the cortical fluid is getting aspirated. So you can do it like for a few seconds, and once you are sure that most of the fluid is out, so you can feed with your rexes. And now you can see here how I'm injecting the viscoelastic to make the iris lens diaphragm concave. And now with the forceps, I was trying to increase the size of the rexes. I find at this stage that there was hardly much of cortical fluid, so I thought that I would continue with the rexes and I would try to complete the rexes. The patient is a little uncooperative, so this is also one more challenge which you get in white cataract, where patients are not able to fixate. I do it under topical anesthesia. So here, what I wanted to tell you was, like, when I injected the viscoelastic, you saw that I injected it on the opposite side of the flap. So always remember this, at times when you inject it in the line of the tear, it can lead to an Argentinian flag sign. So always inject the viscoelastic on the opposite side of the flap so that it lies flat on the lens. And then slowly, gradually, you try to complete. I have completed the rexes. So this rexes was like made a little small, around like 4 millimeters. So what I'll do is I'll plan to increase it later on. So now I'll start with the phacoemulsification. So in this case, I'll be using an IOP of 34 with a fixed vacuum of around 46, and I'll be a fixed aspiration of 46 and a vacuum of 650. So this was a little harder cataract. I usually make a small trench in the center so that I get space to hold the nuclear fragment. And now, when you have an adequate hold, I'm going to do a direct chop. So this was a like 50-year-old patient. So in these cases, usually the cataractus lens is not that hard. So I'm trying to rotate it gently, and so what I do is my foot pedal is usually, it starts from 2 and then to 3, and then I again come back to 2 so that I get a good hold, and then I do a chop. So the rectus was small here, and so I had to be very careful with the use of the sharp chopper, because this patient has opted for an EDOF lens, and I don't want any anterior capsular there. So what I'll do here is, as my capsular rex's size is small, so I'll probably make 6 fragments, small fragments, so that they can come out easily from the rexes and I can do a good phacoemulsification. So I'm trying to break it into smaller pieces, and I bring it in the center. Always, I remember that my phaco hand piece should always be in the center. So I don't move my phaco hand piece. I always keep it in the center, and I do phacoemulsification. So once these small fragments are being emulsified, they are brought in the center, and you can see the side port here. So there is minimal leakage, and it gives you a very good chamber stability. I use active fluidics, so that also adds, and an active sentry also. So even you can lower down your IOP also, and you can do it very comfortably. So once the nuclear emulsification is complete, so now I'm gonna come to cortical aspiration. I'm more comfortable with a coaxial IA. and people can always use a bimanual too. So I start my coaxial IA. So, so what I do here is like, I usually, when I'm under the capsule, my vacuum is slightly on the lower side so that I can get a hold of these cortical pieces, and then I gently increase it once my handpiece is towards the center. So this is one thing which I try, because usually in these white cataracts, you often have weak zonules also associated with them. So that you have to keep in mind. And so you can see here that I've left the subincisional cortex there. So I'll be taking it out later on after my plan here is to increase the size of the rexes and then go for the subincisional cortex. So I'll be using an EDOF lens, a non-diffractive EDOF lens. So in this case, I'll be using Vivity. So it's a very good lens. There has been a lot of discussion before by the panel and everybody. So it gives you a good functional near vision of like around 2032 at 40 centimeter. But it gives, so of course, as Dr. Ramamurthy rightly said, we should aim for slightly myopic, so that you can get a good result. And it has no glistening. Clarion gives you a very good good contrast, less halos, as we already, so many speakers discussed before. So now I'll be like enlarging my rexil. So the chamber should be adequately filled by a gentle nick on the capsule, and I'm comfortable going through the main port. But as in previous surgical videos, they were going through the side port. You can always do that initially, because of course you want a very good stable chamber. So you can see here, I'm trying to increase the rexes, making it around 5 to 5.5 millimeters. And I'm injecting viscoelastic again and again so that the chamber is stable and I'm able to enlarge the rexes without any issues. So once I'm able to enlarge the rexes, my plan is to go for the subincisional cut with the coaxial IA. So, so a trick here to do a subincisional cortex by a coaxial IA is like you can use the double hand technique, where with the other hand you just rotate your tip and it just easily goes subincisionally. And so this way, like how now I'm doing it, so I'm able to take out the subincisional cortex. The lens is centered and the case is completed. Thank you so much.
Excellent
Very nice.
video. Ma'am, go ahead, Dr. Chitra.
Very nice presentation to share, like wonderful the way you manage the fluidics and the technique. And I think if every surgeon does it in a methodical manner, the surgical complications would actually not be there at all, because the exact way you get purchase on the piece and the IUP settings. Wonderful.
Thank you so much, ma'am. Thank you so much.
I just felt that the rexes need not have been that larger, but then fine.
Yes,
Very
ma'am.
nice.
So that was nicely enlarged also. And Dr. Kirti, do you have any thoughts? He was doing an intumescent cataract as we saw.
No, Pratusha, no comments. He always is such a wonderful surgeon. But intumescent cataract, there are so many ways of doing it. One is at baby rexes or the peripheral rexes, or just going in the spiral or the reverse spiral. Which one would you prefer? Because all of us don't have an ASOCT to say where the pockets are, the fluid pockets are. So what would
The
you
fluid in the central portion of the lens. So then what I do is, usually I make a small rexes in that decompressed area. Okay, and then Dr. Professor Chi has beautifully described a technique of capsule milking. So with the cannula, what I do is, because you know that in the central area there is a decompressed area, but there is always high interlenticular pressure in the in the middle and the par periphery. So what you do is you do capsular milking, and in that capsular milking, you gently massage the capsule from the periphery to the center so that the fluid in the mid periphery and the peripheral area is brought in the center and it is taken out. And then what I do in the next step is I take a 25 cannula, I go in the central area and I aspirate the remaining fluid. So you have to remember your fluid, the interlenticular fluid is decompressed now in the central area, in the paracentral and the periphery area, but there is always some fluid in the posterior compartment also, which is there. So what you do is you go with your cannula, gentle depression, just gently depress your lens. The fluid from the posterior compartment also comes out and you aspirate that. So once you do all these things and you use intraoperative OCT also, as Dr. Gaurav has shown as he uses in so many cases, you are absolutely confident that there is no interlenticular fluid left, and then you make a nick and then you enlarge your rexes and the rexes behaves just like a normal capsule. So these are the couple of things which we do, and I would love that other panels and Dr. Gaurav would, if they want to add something further.
So what you're describing is the baby rexes. The baby rexes and the milking and then enlarging the rexes after, reducing the pressure of the interlenticular. The other ones
Yes.
are the peripheral rexes where the maximal pocket is. Have you tried
Yes.
that ever?
Ma'am, I haven't tried peripheral rexes because I'm very comfortable with this. Because in peripheral rexes, if you try, because at time what happens is if you, at times these patients, they have very low ACD also. So if you do, I've tried once in doing a peripheral rexes, but you can be lucky, but at times you can get Argentinian flag sign also. I don't know, like if any other speaker also or a panelist also has tried
Which viscoelastic
peripheral
do you
rexes.
prefer for these? Which viscoelastic would you prefer?
So ideally, a viscoadaptive is a good preference, but I usually use viscodispersive, but viscoadaptive is a better thing to do.
Okay, thank you.
Thank you.
Very nicely done, Tushin. Very beautiful video. We could see everything very clearly and nicely. Recording was excellent. Thank you so much. And yes, I completely agree. What you did is exactly what I do as well with that, puncturing the thing with the, through the paracentesis and, having the aspiration done. But in spite of that, I've had one instance where there was a lady who had very intumescent cataracts. The moment I punctured, I didn't have even time to aspirate. I didn't even get that, 0.1 second. It went into a flag sign. So even then it can still happen in spite of what you do. So you have to be always prepared. And I think femto also has a good role to play here. I prefer to do femtos for my intumescent cataracts. That always helps, where patient can afford it. I think femto is also a good tool. So thank you so much, Tushi. I think we'll have to go on because we are running a little behind schedule. And thank you for sparing time and joining from Amritsar. And we'll see you soon. We would have loved to have you here, but I know you have to go for academy, so it's fine. Thanks for joining.
Thank you so much, sir. Thank you for the opportunity. Thank you.
Let me invite Dr. Gaurav for sharing this video.
Okay, so I'm going to show you this 33-year-old male patient who came to us.
Gaurav, can you be louder?
Okay, thanks for telling me. Can you hear me now?
Yeah.
Great. So 33-year-old male who came with blurring in one eye and high myope with no history of any systemic illness, had a laser barrage in the right eye done some time back. and patient was keen for good distance and intermediate vision, and also enjoys night driving. So we had to think that this patient, although this is a young patient, and we were wondering whether we should offer this patient a multifocal lens. But one problem was that patient was a very high myope, and the other problem was that patient was more keen for good distance and intermediate vision, but also drives at night. So then we had to decide what kind of a lens to use. So we went ahead with all the examination, and most of these things look good. And except for that lasered lattice in one quadrant, everything else was absolutely fine. Patient has a PSC in both eyes, so eventually we'll have to get both eyes operated. Showed some gatte in the cornea, and but the endothelial counts were still okay. And this was the OCT, and you can see the PSC over there right at the bottom. And as Tushya said, we also like to do an ASOCT for all these patients who have a PSC or a posterior polar component or the intumescent. It really helps in knowing what you are doing. The OCT macula looked fine, so patient was good for a lens implant, which we could choose any of those. Now we did the biometry, and you can see that it's showing a small astigmatism of about 0.98, and so it is suggesting that either we use a toric 100 lens, and we had decided that we are going to use a pure C lens, which is the new EDOF I've been using for about nine odd months now. We've already used about 100 plus lenses with good results for distance and intermediate, and very good tolerance by patients for quality of vision. So here we have to choose the first minus. You can see it's showing up as 13 with the first minus on the Barrett's calculator, and also on the Hill RBF, and also on the ILMaster 700 it's showing as 13 diopters with my 0.2 of myopia. So we decided to use this. For the first eye, we typically tend to use the first myopic par, and went ahead. And these are, we like to now, when we do this small table, which is available to us in the OT, which has the toric calculation and the keratometries from 3 or 4 devices. And when I quickly run through it, you can see that, it tells me astigmatism of about 1.25, 0.98, 0.85. And you look for consistency. Then you look for the axis, and you look for consistency here. And then you look at what toric it is suggesting and at what axis. Again, you look for consistency, and if you see outliers, then you can be sure that you want to repeat the biometry and maybe do the repeat toric calculation. But if you see all of them lining up, then it makes life much easier, and you can go ahead with your surgery. So this patient was planned for a femto-assisted cataract surgery with the Pure C. We had been, we've recently started using the upgraded operating system on the Catalyst femtosecond laser, which has iris recognition, and that helps us do cyclotorsion control and toric planning. So let me just run you through the toric planning on the eye. So what the Catalyst laser system does is that it imports data from the ILMaster 700, and once you have that, it can be fed into the laser. So you automatically get the astigmatism and all the corneal calculations, and you can see here you have a choice of nomograms for the LRIs, or you can do the toric planning depending on what you plan to do. You can also use only the anterior case, or you can use the total case, because both of them are imported in from the ILMaster 700, and you can use these for doing your either your LRI planning or for your toric planning and the toric marking as well. So here we have used the Donenfeld nomogram, and then that was just to show you how the arcuate calculation has become so easy now. You don't have to feed anything manually. Everything is imported into the Catalyst from the ILMaster 700. In this patient, we had decided to use a toric lens, so you can see that it also does toric calculation for you, and it marks out the axis and does all that on the Catalyst laser itself. So we've now got these toric marks that we are going to put using the laser. They are put on the cornea, and this again makes life very easy, because you don't have to do any marking, and you don't need the markerless system if you're using this, because there is good cyclotorsion control and iris recognition on the laser itself. So once that is done, you can, of course, the rest is the same as what you would normally do on the femtosecond platforms. And you can see on the top left over here that it says there is a strong match, which means that the iris registration is good. This happens in more than 90% of patients. In another 5-6% of patients, it gets a fair match. And then you can compare it to your preoperative picture and what you're getting here. And usually they match up really, really well. So this brings in a great amount of control on toric calculations and toric, implementing the lens implant, because you get them right on the axis, and then of course it delivers the laser. Going on to the OT now, and here I'm using the Zeiss Artivo system, and you can see the corneal marks. I do put these extra check marks. So this is the mark from the laser, these small linear marks which are there on the cornea, and these will remain even when the patient comes for follow-up few years down the line, you'll still see these marks and you can still see whether the toric is on axis. And here we've made a 2.2 incision. We are using the Veritas system here, which has become one of my favorite systems to work now. As Dr. Kumar said, with the new AI tubing, you can get excellent IOP control, and the chamber stability is very, very good. And it also allows you to, it adds between 20 to 30 centimeters either up or down from what is available on the machine. And you don't have to move the pole up and down, you can just get it on the machine itself. Plus these tubings are good because they're less pliant on the inside and very soft on the outside, so they are very easy to use, and yet the chamber stability remains very nice. So it's fairly soft cataract. And a femtorexis obviously is better centered, and it's the overlap is just perfect. As you could see, Toshe and me were both with the manual rexis, we were trying to make them to the right size and the right shape, so that always makes a difference. So once all this is out of the way, you can see that the cortex is now mostly gone, and I'm now going to remove the cortex. I try to use bimanual systems. As I said already, I like to use a calibrated side port, and here I'm doing something that I like to do. I'm running the infusion and freeing up all the cortex, especially in femto-assisted surgeries. This becomes very easy because you can just use the, I call it as the jet polish and the jet separation of the cortex. It's a jet cleaving of the cortex. You can see that I'm going just under the rexis and using the flow of fluid to separate it out and loosen up the cortex completely from there. Now once this is done, your aspiration of cortex becomes very, very easy, and in one flow it will just come out. So you can get that out in a jiffy over there. And once that is gone, you can do a little bit of polish. And I think we had a small discussion on this earlier on, that if you use viscoat, you tend to have these cells on the lining the capsule become more opaque, and then you have to do this polish. I think it was Dr. Mayank Pangti who pointed that out, and I've kind of reconfirmed what he has noticed. So you can see here, because of viscoat being used, I'm having to clean up the capsule from the posterior part of the anterior capsule. So this is the lens we are using. It's become one of my favorite lenses now. I like these EDOF lenses much more than the trifocals. For of late, patients get excellent distance quality. They are very, very tolerant to refractive surprises. Both hyperopic and myopic, up to 0.25 or 0.5 of refractive surprise will be, patients are still usually reading good 6x6. And of course they come now, this toric platform comes with the frosted haptics, which is on the Technus 2 toric platform. So the centration and the rotational stability is very good. As you can see, I've done a hydroimplantation here and got the lens into the bag. It's a very high myopic eye, so obviously the lens is free floating inside because it's a big chamber and a very deep chamber. And I position the toric lens into position now. And there, once that is positioned, I will seal my side ports. So you can see here that the side ports are nicely sealed. And visual outcomes are very, very good from day one itself. The quality of vision is very good for both distance and intermediate. And patients may need an add of between 0.5 to 1.25 at the most. Some patients don't need any add at all. And there are other patients who may need about +1 of add. So, and most often patients are free of glasses for intermediate vision and some amount of reading as well. So once that is done, you can see that the lens is not perfectly centered yet. I'm probably going to recenter it. So you can see here that I'm just going in and going to put the lens into place, especially because it's a toric lens and you really want to center these lenses correctly. So once you have the Purkinje reflexes nicely covered, you will be all done. So once all that is done, I check for the IOP. I like to put a drop of trypan blue to check whether my ports are sealed perfectly or not and whether they are leaky or not. I call it as the trypan blue seals test. I've been doing this for a good number of years. You can see a small leak there on the side port. But if it's a very small leak, I will not bother about it. If it's a bigger one, then I'll probably want to go back and seal it again. So after that, a little bit of intracameral moxie and also to seal the side port with the same thing. and that should be done. So I think this has become a very, very useful technique and a lens that I like to use now. And with that, I'm done. And if there are no questions, then I'll just have to move on to the next session. There are still 2 surgeries to go. If there's any quick question, Dr. Kirti ma'am.
Very lovely surgery, Gaurav, and everything's explained beautifully. I think the toric markers come to even greater play in a small pupil situation.
Yes.
You know, wherein you're far more relaxed. You don't have to be so concerned about retracting the iris to identify the toric marks on the IOL, and this bails you out in that moment also.
I completely agree, ma'am. You know, and they have become useful because now you don't have to really depend upon the markerless system because that may be available on one of your microscopes. You may not have it on all your microscopes. So this just makes it much easier for your toric marking and your arcuate planning as well.
So that means there's no need to mark it on the STETI.
No, you don't have to do anything, no. Because the ALMaster 700 exports data to the catalyst and just does the iris recognition and toric marking. Thank you, ma'am. So I think now we are going to go on to the care group session where we have 2 very interesting surgeries. I think Dr. Chitra is doing an IPCL and Dr. Gitansha is going to show a clear procedure. So I think we'll invite you on Zoom. The audiovisual team can please connect to the audiovisual to the Zoom platform.
Should I share my screen, Gaurav?
Yes, ma'am, please.
Can you see my screen? Are you all able to see my screen?
Yes, it's Chitra, it's visible. Please carry
on. Can you hear me too?
Very clearly.
Okay. Very good afternoon to one and all of you. I think it is the most unfortunate week for me that after so much of planning to come to Jim Corbett, calling up Dr. Satanshu, Gaurav, Saurav, like fate had its own way to play back with me and I had to present online. But it was really nice watching all your surgeries and thank you so much for your hospitality and warm invite. I shall go on to talking about the implantable phakic contact lenses, the IPCL, which is the Indian version of phakic IOLs, and they have stood their stand and definitely a very promising, not just in the primary correction, but also in those extreme situations with the ability to customize these lenses, like keratoconus or more. So basically, this Nandini is a young 23-year-old female, -7 with 1.5 cylinder in the right eye, which was to be taken up for the surgery. Basically, she had both eyes were operated on the same sitting for this patient. Pre-operatively, the topography was about 524, normal, orthogonal astigmatism, and Bellins was absolutely fine. So was the Forbes. It's also important, I skipped fast, but in the Pentacam, it showed as 2.72. It was shocking. I thought, my God, I can't do it. But then when we re-looked at it and the anterior, it showed that the patient had an anterior chamber depth of 2.86 from the endothelium, and that was encouraging. We did repeat readings again and again, and then fed in all the data, the K value, the anterior chamber depth, the PACI, and as we all know, there is this transposition of the spectacle refractive error, which is done. And the other advantages, before I go on to this, in this IPCL, all the lenses can be placed at 0, 180, and it is customized in such a manner that it does the astigmatic correction while being placed at the 0, 180 axis. So that's one extra point to know. So let me take you on to the surgery. Basically, it has 6 haptic pads and large holes, which takes care of any oversizing issues. It has a left leading knob and a right trailing knob, which gives you the direction. And it has 6 holes, 4 paracentral holes and 2 peripheral holes. And the central hole is 400 microns. And it is made of a hydrophilic material, comes in 5.7 to 6.2 optic zone and 11 to 14 overall length, and it's DSS is used and it's loaded in the cartridge in a it's so absolutely easy, like in any plate haptic lens. you get the Varion overlay. I've kept the pupil myosed here. I do not want any remote chance of a lens touch. So the registration is done because it's a toric IPCL which is going to be implanted. So I just make within the limbus 0.9 incision side port at 3 o'clock and 9 o'clock positions. And I have just, after making this incision, I have not used viscoelastic. I have not yet used phenocane yet. And I would just fill it up with just a little bit of BSS. And then I would take my 3 millimeter keratome and make my central incision. Now this is done. So I avoided any challenge of a lens touch in a dilated pupil. I now go and inject phenocane. So all my patients come with an undilated pupil, and with the phenocane, the pupil completely well dilates. I don't want over dilatation either, because I would like to see the haptics being tucked in the sulcus, and just about appropriate. And now I prefer, over the years I've used methyl cellulose, but now I prefer to use Helon because of the absolute ease in evacuation of this high viscosity viscoelastic. I would again not over distend the eye, just adequate. And the lens has already been loaded, as you very well saw. So I just nudge it a little forward in the cartridge and ensure I gently unfold such that the left leading knob is where it should be on the left side, the right trailing, the convexity above. At any point of time, if I feel it's not getting unfolded,
recording
the lens is
in
well
progress.
centered, and you are very sure that the haptic pads are in the sulcus. Now I have to remove the viscoelastic. Now that's going to just take a minute. You can see it already washing off, even without my using an IA. Now I have this Varion marker which is there. Now basically it has the central line and the dotted lines. The idea is that the IOL marking on the IPCL should be on line with the central marker. Maybe it could be parallel both up and below along the central marker, but ideally on the central line. There is this arc on the side. The knob should be right in the center. If the knob is right in the center, the cyclotorsion compensation has happened. But I do feel that at one end it is right on the mark, and sub-incisionally it is a little off the mark. So I would go and nudge it a little. It is really nearly there, but I would be extremely sure, like whether it's a toric IOL, but even more so with a phakic IOL patient, because we are correcting high cylinders. So even a small error in axis would actually leave a significant refractive surprise, which is not acceptable at all. And then the viscoelastic is already removed. I would hydrate the stroma, and I would inject in intracameral moxifloxacin for all my cases. I would be very conscious that would I finally really nudge it here and there, ensure it's absolutely bang on axis. The knob in that arc which you see on the side is right on the center, so that it tells you that it's completely on line and on axis. And once it is done, gradually remove the speculum, and even then have a view to see whether there has been no rotation at all. And post-operatively, needless to say, if you do it carefully, it's a very straightforward procedure. Patient sees plano 6-6, and the next day very comfortable. And I would like to do my anterior the day one, and if there is any doubt, I would repeat in a week, but I would do it after 6 weeks or 4 months. And there's a good
Ma'am, on the anterior, does it show some kind of lenticular changes in the anterior subcapsular area, and it's looking like here?
No. It's maybe just the quality. 554 is the void, and that is absolutely brilliant. And I think I have come to the end of it.
So excellent surgery.
Do I stop sharing my scene?
Yes, and just wanted to ask you a few questions about your surgery. So one question was that you did show that the AC depth was different on the two devices, and I've experienced the same thing. Sometimes the Pentacam is showing 2.7, the anterior shows 2.8. So what I have also now understood is that AC depth is not the most important thing. It is actually the lens thickness and the crystalline lens rise. So some of these newer nomograms which are available using the OCT based parameters or the UBM based parameters. These are able to give us a better judgment of the ICL sizing. Even when the AC depth may be smaller, you can still get very, very good ICL sizing and calculation, and you can still use.
But I would still beg to differ that I would not like to compromise my AC depth anything less than 2.78. I might repeat it again in Antirion or any other OCT device to know, but I would not put an IPCL or an ICL for a 2.72 AC depth. And I would definitely want to do a gonioscopy to look at the angle. Doesn't make sense to compromise at all in these patients.
Again, ma'am, beyond gonioscopy now, the angle opening distance and the angle configuration on the OCT devices has been giving us a lot of peace of mind. And if you do the correct sizing, and in fact now you can customize the size of the ICL, especially the IPCL allows so much customization in steps of just about 0.2 millimeters.
0.25.
So I did one patient who was having a myopia of about -10 and a young girl, and she was having a AC depth of 2.68 and had corneas of 470 or something, and so there was no chance of doing and she was into a situation where it was a wedding situation coming up, and it was imperative that she get some kind of a surgery. So after a lot of dilly-dallying for almost a month or two, we customized the lens from IPCL, and they made us a lens, and her white to white was smaller also. So all the things were wrong, but eventually using all these new measurement methods, we were able to get a smaller ICL made for her, and we had a great outcome. We had a 500 micron vault, and after that, even though the white to white was smaller than what STAR predicts, STAR doesn't give you a calculation below something like 10.5 or 10.7, I'm not sure, but we had in a white to white in the slightly smaller than that also, with an AC depth of just about 2.68. So it may be a one-off result, but there is hope, and there are now recent studies which have shown that 2.8 is not the like the gold standard at all, and a lot of new data coming up on slightly smaller AC depth. Not that I'm trying to promote putting ICLs into, because you have to do it with utmost caution, and I typically explain to the patient that I may just pull this lens out, and since I have intraoperative OCT, I was able to check it on table and be sure that my vault size is correct, and that's how I left it in the eye, and we got a good result. But I think it requires a lot of diligence, and that's more the exception than the rule. But that was beautiful, ma'am. And also one quick question about sodium hyaluronate. It was very nice to see that you could get the sodium hyaluronate out even without doing any kind of wash, and that's how the very few chances of IOP spike, I think. Do you monitor patients? At what stage do you monitor them for IOP spikes?
Actually, honestly, ever since we've shifted to Hylon, even with viscoelastic methyl cellulose, there was very rare issues of IOP spike post-operatively. But now with Helon, I have not had a single situation where this has happened. And we are all of us doing big numbers of phakic IOLs. So I think all of us are very conscious about removing the viscoelastic thoroughly, and of course washing it. And with Helon, it just comes out as a bolus. So I don't think IOP spike is an issue at all.
Perfect. So I think we can go on to Gitansha's surgery now. And she's
Thank
been
you.
very patiently
Thank you
waiting.
so much for the opportunity, Gaurav.
Thanks, Dr.
Saurabh,
Chitra, and I can see that
Satanshu.
you were not well at all. I could quickly get a glimpse of your hand, having still some tape stuck on it from your treatment. So please get well soon. And thank you for, in spite of your, small predicament, you've been coming online to stay with us for these couple of sessions. Thanks a lot. And we are missing both you and sir at the meeting. So all the same, I'll request Gitansha, and it's very good to see Gitansha back on the circuit. Gitansha, can you start sharing your screen, please?
Thank you, sir. Very good evening to all of you. Today I'll be presenting a case of corneal lenticule extraction using the CLEAR platform. Is my slide visible, sir? Can I go ahead with the video?
Yes, please go ahead. Yeah.
Right. So I initially start by extending the markers of the slit lamp using this 3-blade marker. The centration here is done on the corneal vertex, which would essentially be on the first Purkinje image. So then we go ahead and enter the patient's treatment data. You'll notice here that you also have something called the Q factor at the 8 mm zone, wherein you can enter the corneal sphericity from before and the machine retains it, thereby perhaps reducing the spherical aberrations that the treatment would do. Then we move on to the centration of the treatment. Now this can either be on the pupil or it can be manual, wherein it is centered on the applanation video, or we can do it on the marker, which is what we're going to do in this case, where it is centered on the corneal vertex marking and the limbal markers for the cyclotorsion. It gives you a wide zone of optic zone diameter, almost from about 4 to 9, and the cap thickness. Another important advantage of the Clear software is that it offers you 2 side cut incisions if you want an additional one, wherein you can get one which enters into the anterior lenticule plane and an additional one which enters into the posterior lenticule plane. The second one can also be used as a rescue incision in case of in a case where the lenticule has been delineated in the posterior plane first. So this is a single dock wherein we have docked the suction ring and the handpiece onto the eye. Once the vacuum is initiated, the machine will then recognize the pupil and the limbus borders. So this machine allows you to change the centration even after the dock. You can see that we're manually centering it on the corneal vertex, which is now followed by the cyclotorsion compensation. This has an intraoperative ASOCT where you can see the plano-convex nature of the lenticule. We then proceed with the femtosecond laser delivery. Now in this, both the anterior and the posterior cuts are in a spiral in pattern. This additionally allows wending incisions for the anterior and the posterior plane. This is essential for the egress of the excessive OBL because this has a flat applanating dock, and this is followed by a side cut. So we go on to open the side cut by entering vertically down. The stop sign can be used to correctly identify the anterior and the posterior delineation. Now when you're doing the dissection in the anterior, it's just important to do it end to end, but here you can see that there is a slight resistance at the junction of the cap cut and the venting incision where one has to be a little more cautious. So I then proceed to complete the dissection on the other half as well. Moving on to the posterior dissection, I like to do what I call as the wedge technique, wherein I first do an inferior dissection on both the left and the right, and then go on to leave this small undissected wedge of tissue before completing the superior dissection. So how this helps me is that it prevents the lenticule from moving or folding over while the subsequent maneuvers are happening. Then proceed to just dissect that undissected wedge that was left behind and remove the lenticule. And with this, the procedure is complete.
Very nicely done.
Very, very nicely done, Gitancha. And I just wanted to ask you, because again, you have experience with all the lenticule platforms, and the Clear seems to be one of the very, very nice platforms to work on. And I did see that you have the option of doing the side cuts in such a way that you can access the 2 planes, which is not possible on the other platforms. Also, I saw you do the cyclotorsion control with that marking. I heard that they are also likely to introduce a new, link with one of the imaging devices which will allow cyclotorsion control to happen with iris recognition. I'm not sure. At the ESCRS, there was this new thing which I saw where it is linking up, I think, to the Galilei or something, one of these machines. So, do you think the Clear has, come of age, and are you getting excellent outcomes like what we were getting with Smile, with the Visumax 500 or the 800? Are we getting good 6x6 patients on day one? And what's the learning curve like?
So essentially, sir, I'll just go one by one. When you compare all the platforms, Clear does have a higher pulse repetition rate, and it has low energy per pulse. So what you're getting is highly focused energy, and it's overlapping spots. So since there's no spot spacing, the dissection is definitely smoother as compared to the other platforms. In silk, the dissection is smooth, but essentially I think because of the morphology of the lenticule, often even I in the beginning entered the wrong plane first. That rarely happens on the Visumax or even on the Clear. When we're talking about the centration, so we're right now doing it manually, wherein we are marking the first Purkinje, which essentially would be marking the corneal vertex. But this clear can be linked to the Galilee, and I think in the future, the next step would be to upload the Galilee data, wherein the corneal vertex is taken from there and it is not marked manually, just to see whether it is creating slight aberrations post-operatively. Because the Visumax is centered on the visual axis, and I did a study where I compared smile eyes versus clear eyes. It's currently under review, where we compared about 300 eyes each. The horizontal coma that was induced post treatment was slightly higher in the clear group as compared to the smile group, though it was not significant. Now, this could be the horizontal coma could be slightly higher because the manual marking that we're doing might not actually correspond to the corneal vertex. I guess once the ability is linked, we will get better outcomes and better centering on the corneal vertex. The post-op visual recovery on first day, when we compared both the machines, was slightly delayed in the clear group as compared to smile. But again, the results were not significant. This was in a single center study in our branch. At 1 week, the visual results are exactly the same. But the advantage of clear is the mobility, and we've been using it over 5 centers over the last 2 years or so. So it essentially goes one branch, so the 5 days are fixed and it goes to the different branches. And I just learned today that the machine has traveled 150,000 kilometers in the last 2 years. So there, I think because of the energy optimization against the different centers, and because we have to recalibrate the machine, the visual outcomes on the first day are slightly inferior, but within a week, the outcomes are equivalent to all other platforms.
That's great. And also the versatility, because you don't need a separate OR for this machine. You
Correct.
can obviously move it between centers, and you also can place it in your cataract OT as well. So you don't need a separate OT, you don't need separate infrastructure. And also the fact that it can do femtosecond cataract surgery and lenticule and flaps and all the corneal applications. So are you guys using it for corneal applications as well?
I think as of now, the centers are mainly using it for the refractive procedures and for flaps.
But I heard that cataract, because Kumar is using it and he says the cataract is excellent.
Yes, sir. We're very happy with the cataract
So I
procedure.
think that the future is with a platform which can do all these things together, because you have 3 separate rooms for 3 different lasers, and you can put this into your existing OT. Nothing better than that. And if the results are great, I think this can be a big game changer for this industry, for the lenticule platform. So also a last question before you leave, because we are at the end of our session now. Is that do you see any other new developments coming into the clear platform, like customizations? Lenticules have been around now for almost 10 years. Hyperopia is still not, I think, only on Smile. They've just launched it on the Visumax 800. But do you see further evolution in lenticules so that it tends to replace excimer to a large extent?
So essentially, one like we spoke about, sir, I think they're thinking of linking the Gilly to it, so we can import the corneal vertex. And the other, I'm not particularly sure, but I think instead of the spiral in pattern, I think they're thinking of going in for a raster pattern now in order to make the dissection better and smoother.
Right. That's what is there on the silk, right? On the Elita. Elita has
Yes, sir. The Elita has a raster pattern. Yes.
Perfect. Great. So thank you so much, Gitansha, and very happy to have you with us today. And thanks for joining in and taking out your time. And wish you all the best. And we'll be signing off now. Yours was the last talk for the day today in our live surgery session. Thank you for logging in, and I would like to thank Care Group also for getting both of your surgeries onto us from Coimbatore. And have a great day. Thanks to Chitra ma'am.
Thank you
also.
so much. Thank you.
Thanks to Chitra ma'am. Thank you so much, and get well soon. Thank you.
Recording stopped.